we are, the structure of the forum, we are not going to have a presentation, but we are going to have discussions through my eminent panel here, which will lead us to the desired outcome. After the panelists introduce their subject based on my questions, we will allow the group or the participants to raise some questions and comments that can help us to further. The comments should not only focus on what the panelists will speak, but also we can discuss seeds of next year's forum, what we are going to do. So feel free to be an open ground. So many of you know me, so I will introduce my panelists because I will not have time to introduce them as I speak. So we have Maria Magalala on the immediate left. She's an expert, she's a doctor, an expert in public-private partnership. She has a Master's of Arts in Project Management, and currently she serves as an advisor on to Bakwata, public-private partnership, but also she chairs the Muslim Social Services Commission. This is a new entity which is being established, and we are going to hear a bit about it. Then we have Dr. Abbas Musa. This is a registered medical doctor. He has over 8 years of clinical care and medical insurance expertise. He's a medical manager at ARIS, but he serves as Deputy Secretary General of Jamii Bora Health Services. You might see, if you follow his CV, you might think he's demoted because before he was the Secretary General of Jamii Bora, but the structure has changed and the position of the CEO was removed. Instead, we have the SE. So you have to explain your CV because people might think you're walking down. Then we have Dr. Zuena Kondo. She's a medical doctor, a public health specialist, has worked with many corporates, NGOs, and the government. She has extensive experience in monitoring and evaluation of public health interventions. So we have really a strong panel that will help us to reach that. So in order to get what we have, I'll start with Maria, Dr. Maria. Can you give us an overview of Bakwata in general and specifically the roles of the Muslim Social Services Commission?
Thank you very much, moderator. Good morning, everybody. Yeah, Bakwata, an overview of Bakwata. Bakwata is a Supreme Council of Muslims in Tanzania, was registered as a faith-based organization in 1968 to represent the interests of Muslims in Tanzania. And Bakwata is located in all 26 regions of Tanzania, mainland. The aim of the governing body of Bakwata is to promote unity among Muslims, communities, economic development, education, health, women in development, peace, and justice. Bakwata has successfully partnered with various stakeholders at all levels and has effectively implemented several health programs that have positively impacted the lives of millions of Tanzanians. And in 2018, Bakwata established Muslim Social Service Commission. The Muslim Social Service Commission having 14 members. Some of the members are here. And the Muslim Social Service Commission is entrusted in moving forward the agenda of health and social services. The role of the Muslim Social Service Commission is as to supplement, as a supplement complementing government efforts by enhancing the delivery of quality health, education, and other related social services in Tanzania. And also the other role of the Muslim Social Service Commission is to promote and strengthen cooperation between the local and international NGOs with similar intent and the goals to support social services in Tanzania. And another one is to coordinate, to support and coordinate and supervise organizations established by BAKWATA and other Muslim FBOs that operate facilities and centers for provision of social services to the community. And another important role of Muslim Social Service Commission is to conduct, guide, and to support research for sustainable social services. Thank you very much. That is BAKWATA and the Muslim Social Service Commission.
Thank you very much, Dr. Mariam. She has given us a snapshot of what BAKWATA is and the body which has been established to further the social services. What we are going to discuss following is what BAKWATA does, but not only BAKWATA, but its affiliates. BAKWATA is a faith body, and it looks over at many other Islamic FBOs which are working under BAKWATA. Some of them are more independent, but they're all working to further the same goal. So, Dr. Abbas, what is being done by BAKWATA currently to further the agenda of PHC in Tanzania? But also, you can highlight what some of its affiliates, like Jamii Bora, are doing to catalyze the access to PHC in the communities.
Thank you very much, moderator, Dr. Ipuge. In general, BAKWATA is what is a faith organization and a major body has done a lot of efforts to address UHC as well as primary health care in various modalities. One among the area, BAKWATA has put an effort to establish a number of primary healthcare facilities in various regions. Currently, around 15 regions has a number of projects at various steps. Some they've been completed and they are working, some are under construction, some at groundworks. In all these 15 regions, we are covering around 40 districts, including Kibaha. We have a new project there, launched recently. Ilemela, Bukoba, and several areas. In this area where BAKWATA is building the facilities, it ensures that members of community are getting access to health care at closest areas they are living. Apart from that, BAKWATA is running a number of projects that touches the community needs, including the area of reproductive health, where there are several projects in prevention of gender-based violence, and training to adolescents and youth regarding the reproductive health. Going ahead to several affiliates of BAKWATA, including Jamii Bora, we have SME, we have and others alike. Jamii Bora is a big umbrella for health, Muslim health professionals. We are doing a number of community-based activities that most of them are addressing the agenda of UHC as well as HC. Then looking at some of these events, including several medical camps. Our medical camps are integrated camps, means they have a number of activities within that address several areas several areas of health, including these gender-based violence. In several camps we are going. Actually, we do trainings to madrasa teachers, those who are handling children at madrasa. There we are training on gender-based violence, and we have covered currently around 7,000 madrasa teachers. And also, we do capacity building to local health professionals. Is our mission that we do save those underserved communities, especially those in remote areas. Currently, we've gone to Zanzibar, for example, and we saved the community in the Kivunge area, where we saved around 6,000 individuals with preventive services like health checkup, screening, as well as we've gone further to do some surgeries that were community members were in need of, but they were not getting them because of a number of reasons. Thank you very much.
Thank you, Dr. Bassi. I know I gave you a lot and you have discussed them in a nutshell, and we might come back as members ask some more questions. Now, Dr. Zuena, you are an M&E expert, and whatever we have said here, we are like beating our chest. We have done this, we have done this. Is it all rosy? Are there any challenges, or are we facing as BAKWATA, and what are the opportunities are there available to further this opportunity of UHC?
Hello? Okay. Thank you. Na wasalimu kwa jina la Jamhuri ya Muungano. Thank you so much. As moderator, Dr. Ipuge, my chief, my mentor, has alluded that even though we have mentioned here a lot of things which we have done, but in the field, as you know, we cannot not go without challenges. So in this mission of providing primary health care specifically through services to people through the health facilities, for BAKWATA, first of all, we have this kind of major challenge is the legacy of privately owned affiliation to BAKWATA when the private facilities were banned in 1977. I know around this time, like me, maybe I was just born, but private healthcare facilities were banned in this year. And because of this, only private faith-based were allowed. So a couple of private facilities who could affiliate to BAKWATA, they were affiliated to BAKWATA, but BAKWATA could not directly supervise and coordinate them. So for those who poorly performed, it had affected BAKWATA system, and also credibility. So we still have this challenge, which, as Dr. Mariam has said, this commission is also charged to ensure performance is being maintained and retained. But also there's a challenge of mobilizing resources, as we say. The resources are inadequate. As a result, these healthcare facilities, even though they are there, they have limitation in staffing, but also equipment. Equipments are also it's a scarcity. And also inefficiencies in implementation, capacities for this staff and other management officers is also not much like you compared with the ministries officials. For these are the specific challenges for BAKWATA, but as we know, overall, challenges of primary health care, we know we have very rapid urbanization and demographic changes across the country. This is a challenge not only to BAKWATA, but to other faith-based organizations, but also to government. Also emerging and re-emerging diseases. We all know about the COVID-19, the Marburg, and others. The increase in non-communicable disease trends, which is now widened, the disease burden, and the demand now, as a result, the demand for health services has largely increased. So all these are challenges which BAKWATA is facing together with other providers. But we have opportunities. We have opportunities, as we have said. BAKWATA has initiated an initiative to build at least one health center in each council. Kagera and Mwanza regions are leading in this effort with 6 and 5 health centers already under construction. And other regions in the pipeline, like Tanga, Tabora, Rukwa, Katavi, and Shinyanga. Dr. Mariam had talked about Muslim Social Services Commission, which had been initiated since 2018. So now this commission has been charged with the responsibility for establishing a management system and a quality improvement system for the BAKWATA and other Islamic FBOs. So through this system, there will be a standardized system for quality assurance in all these health facilities which are being improved and being constructed. And other opportunities, as we know, the government of Tanzania has a public-private partnership, very strong policy and system. So this is an opportunity to BAKWATA and other FBOs to utilize this to improve our health care. Another opportunity, as we are all aware now, the government is strengthening the community health program. And we know, if you talk about community, you cannot not talk about the faith-based organization. The faith-based organization are the ones who are there with the local people. We understand the people, what are the needs, and the people trust us. So we believe that through this journey of community health program strengthening in Tanzania, the faith-based organizations will be given a very special role and a very large visibility to ensure that the community healthcare system is really performing and functioning. And at large, we know with the universal health coverage, just a few weeks ago, last month, the world leaders had convened in UN and had agreed on the new political declaration on the universal health coverage. And in this declaration, it has recognized the fundamental role of primary health care in achieving universal health coverage. And therefore, this is the large opportunity for BAKWATA and other faith-based organizations to increase and scale up our activities in strengthening primary health care services. With that, asante.
Asante sana, Dr. Zuena, and all the panelists. I think what we have tried here is to, in a nutshell, to show what is Bakwata and its affiliates are doing, what are the challenges they are facing, and what are the opportunities of going further. We thought that this is the best way to stimulate and to raise the discussion from the floor, but I think many of us might be wondering, we have been told that Bakwata is now building facilities in each council. We know also the government is building, has done a lot on that, and so maybe Dr. Zuena, because you are the MNE, can you tell us, and Dr. Abbas, so what is, and Mariam as well, what is the value add of these new facilities while the government is already building, has built, and what will be new in those? What is there? Can anyone join us? Start on that.
Thank you. So the question was, what is new? Well, as you know, faith-based organizations are the organization which knows the local people, the context and the need. So specifically for Muslim organization, Bakwata and the affiliates, we know we have cultures and tradition which are Islamic basic. So one of the added value is that we are planning, and we have other facilities which are already running, like as SMV. We are planning to build facilities which will provide women services only for those who will be attracted to that. That is going along with our culture and you know, and our values. So that is one added value which it goes with the rights of providing health services, the rights and the gender and equality. So if someone is prefer to get services with the same gender, like the women, this is where we are adding value. That's one area. Thank you.
Thank you very much. Another area is that we know that Bakwata is complementing government efforts. And we know that the government is having some gaps. It's not that everywhere there are facilities. So we are going to complement what is the government doing. This is our role as Bakwata. So complementing, bridging the gap, what the government hasn't done, Bakwata will do. Thank you.
So I would like to open up a bit because I've been asking questions. Maybe we can get a few hands from the floor. If you have any questions, you are not restricted to what has been discussed here. You can open up anything so that we can, as I said, it can also help us to think further. So please, thank you. Kuna mtu akunisaidia? You are, okay.
Asante sana. Based on maybe
kwanza we nani, unatoka wapi, ndio swali.
Yeah, mimi naitwa Kasim Tani. I'm working with the Fakara Health Institute. I'm a researcher. Based on most of added value to the primary health care have been mentioned, like construction, services, the thing which is most maybe the community wants, having gender services. But we have the challenge on having those services paid for. It means that, okay, issue related to financing these services, because we have, even, okay, with Islamic culture, there are challenges within how is maybe with this going on effort, seeing how we can tackle the challenge of financing based on the culture, Islamic culture.
I'll pick a few more questions before we. So I have a hand there. I have a, okay. Okay, I start you first, and then I go back, then I come forward. I've seen you all, and yeah.
Yeah, good morning. My name is Mgeleka. I work with the USAID, Afyango Northern. Thank you so much for interesting discussion, especially on the effort that BAKWATA is doing to increase availability of primary health facilities in the community. My question goes to the component of affordability. If we are discussing on the universal health coverage, we cannot ignore the fact that affordability of these services is very crucial. So what is the position of BAKWATA to ensure that the community are affording those services being provided in those primary health facilities? And this goes along with the fact that the government is tabling the bill on universal health insurance. So what is the position of BAKWATA to push the very same agenda of universal health insurance for all?
My name is Sayoki Mfinanga. I'm a research fellow with the National Institute for Medical Research. I was so happy when you mentioned about non-communicable diseases as a burden that is a challenge in our health system currently. And personally, I feel that we need a very strong primary health care to deal with chronic conditions. So in your opinion, how should, because we have very strong primary health care in terms of communicable diseases. If you ask me about HIV today, I give you figures. You ask me about TB, I give you figures. You ask me about malaria, I give you figures. You ask me about diabetes, hypertension, then the challenge comes. How should we change our primary health care to be able to tackle the double burden of increasing non-communicable diseases and while we still have communicable diseases? Thank you.
Asanteni sana. I'm Josephat Mshigati. I come from Pathfinder. I work in the nexus between health and climate change. I'm so happy from what BAKWATA is doing. I just want to pose one more challenge to you. In the area of climate change, we see a lot of impact on health. When we have prolonged drought, we get water shortage, and that affects a lot primary health care and children in school, everywhere. Food insecurity, nutrition insecurity, all those are core issues. Now, that is going to be staying with us for many years to come. So how is BAKWATA prepared, as much as we are doing a lot of work in health? How is BAKWATA prepared to integrate health, climate change components in your health interventions? I'm aware there are some UN bodies which provide funding for that. However, it's competitive. I wonder whether BAKWATA has applied for any climate change and health funding. The last one, just to say I'm available also to work with BAKWATA to develop programs on health and climate change. Asante.
Good morning. My name is Omar Buguyu. I'm an Assistant Director for Non-Communicable Disease from the Ministry of Health. Mine are almost a suggestion. One, it could be important, based on our topic, could share the strategy that Bakwata has, because we haven't seen any strategy. So it is very important in this kind of forum to see what is our current strategy from Bakwata and what are the priorities at this particular time, because we know we have a lot, but we need to prioritize. So it will be very important for us to understand these are the Bakwata's priorities so that can chip in if it is possible. And the second one is on complementarity. I know many people who want to invest on health, they are very much obsessed with construction of the infrastructure supporting the healthcare system. But unfortunately, when you look at the angle, how Bakwata is operating, you failed. Because we had Arafa dispensaries and they belonging to Bakwata. There's a mushroom of Arafa dispensaries we failed to manage, and most of them are now privatized, and they are not faith-based anymore. So it is not necessary that we go to the community and construct again, because labor intensive, you need a lot of capital to make sure that you have it. But in the position of a religious organization, there's a lot to intervene. For example, Professor Mfinanga is talking of NCDs, and we know for sure most of our risk factors are lifestyle. Muslims have good culture, which once we communicate and educate most of the Muslims could probably be prevented from the NCDs. So how are we going to invest on the lifestyle taught from the Holy Quran and Hadith could probably help in fight against NCD. And that could be part of the innovation from Bakwata. And rather than using a mainstream culture on health care, which we have shown that we are not competent on that area. So mine was the association and look at other angles rather than using the routines. Thank you.
But the only woman who raised her hand is the last one here. It's because I give them importance so that we can hear last.
Okay, thank you so much. My name is Dr. Asha Mahita, working at the Ministry of Health as head of referral services abroad, but coordinating medical tourism. I would like to say thank you all presenters for the nice presentation. I have suggestion. It's not like I don't have any question, but I have a suggestion. I heard about you are constructing facilities in different regions. And you know, at the moment, there is a lot of production of health workers, I mean doctors, nurses, who are not employed. I think it's an area now you can make an environment whereby those hospitals to have an MOU maybe with those doctors who they can run those facilities. Yeah, at the point it will be like you are helping the government to absorb those health workers. But in another things, like at the moment, as you know, the government has an agenda of medical tourism. So it's a time now to Bakwata to think, how are you going to chip in that agenda? Yeah, thank you.
We should take those questions and we respond. But I would like to thank you, all of you, for that. It appears you are well engaged and you have really raised important questions. My panelists, I make it free for all. And now in this case, I'll also be a panelist. So if any question is not answered, I'll tackle it. So we start with Zuena coming to my direction.
Thank you. Thank you so much for all your questions, which it has shown that you were listening and you were interested. Thank you so much. So I think the first and second question kind of similar. It's about financing. Yeah, my brother there from Ifakara and my brother from USID has asked about affordability and financing. I think this is one question, and I think here Dr. Ipuge will chip in. From far as you have said, what are we planning? First of all is to work with the government with this bill. Work with the government to educate the people in line with the government plans. The advantage of having a universal health insurance and all that, because we are close to the people and we are the one who sometimes they can listen and understand. But we have, currently, when we don't have the universal health coverage, we have other means. For example, we have a wing of sisters whom they have a fund to provide health insurance for the children who have need. So up to now, they have covered up to 100 and plus of children who have these needs. My other colleagues will touch on this. There was my other chief there, Professor Mfinanga, talked about non-communicable. What should we change to our primary health care? I think we should mind first that it is not only communicable, it is also non-communicable. So we have, yesterday I learned something. It's not only about documents, guidelines, but it's about what we are telling the community. To hear what we are telling them, what is the problem, rather than just kimbilia kutengeneza guidelines and they're there in our drawers and everything. So what we are supposed to do now is to go and give this message, and we as BAKWATA, we are supporting the government, the Dr. Ubuguyu's department, where we have now strategies for non-communicable diseases. And the government have started integrating these non-communicable diseases with other services. So BAKWATA will continue, and we have taken this in the strategies. This should be very visible. Climatic change. Thank you so much, my brother. Yes, I think this is the root of all other problems. Like yesterday, I listened my other mentor, Dr. Swai, presentation about stunting, how it's affecting us. And so this is another area. I'm sure we are going to take this over. Dr. Mariam will talk about if there's anything has been done. But I think the opportunity here is the pandemic preparedness declaration, yeah? I think it has strengthened about this, and this is the area which we will have to take up. I don't think I have any specific. The question from my young brother, Dr. Ubuguyu, we should not concentrate on just constructing health facilities, because by history, BAKWATA has not been performing well, and we have talked about this, why BAKWATA did not perform well, because those private facilities, they just took the BAKWATA name, but unfortunately BAKWATA could not coordinate. But now with this commission, it has been charged to establish that system to ensure for these ones which are being constructed, then quality will be ensured. But the question, the issue of focusing on the lifestyles is very important, and I'm sure it will be taken aboard. The HRH is very crucial, and I think we have taken it as a note so that we can contribute to the government. Thank you.
Okay, we have short time left, so very quick, Dr. Abbas.
Thank you very much. Hope I won't repeat what has been said before. Just to put a word on first question, second question, will look similar. what we say not as Bakwata and what their affiliates, specifically in Jamii Bora programs, where we go directly and address issues to the communities, including what the services, how these services would be affordable, as well who is financing these services. In fact, what we say in general that unless Muslims stops to give charity, then the world will continue. This is a very known message in for most Muslims, that Muslims shall keep on giving charity, endless. And once they stop to give charity, now the Almighty God will take his word. Through that, we are passing our services, that most of our community services, they are financed by charity, where we have done a number of community services, including Kibaha camps. Kibaha camp, 100% is coming from charity. We have this gender-based violence program, a number of trainings that have been done, and the coverage of more than 7,000 teachers. All of them have been financed through the charity. And take what Jamii Bora, for instance, has around 10 years moving on charity. So unless we stop giving charity, then we know that this can be what can be financed. The other area of finance then will go as the previous speaker said. Number 4, 5, and 6, regarding on climatic change and the challenge on primary health care, as well as the Dr. Buguyu's comments and Dr. Asha's comment, then I think are comments to be taken and worked on. Thank you very much.
Thank you very much. On financing, actually, we will add also public-private partnerships. I'm partnering with many individuals, with donors, with other organizations, etc. Coming to NCD and PHC, the most important thing is to integrate it. We have to have an integrated approach. An integrated approach will help us, for example, somebody who is coming to the CTC should be checked also for diabetes and hypertension. So if we integrate services, we will move further on NCDs. And also, if we have community-based programs, and Bakwata, we are embarked on community-based programs, whereby we can use also community health workers. We know that community health workers, they go to the households, and they can be able to sensitize communities, whereby they can come to the health facilities for checks. And they can also sensitize communities and the households during community screening for diabetes and hypertension. And also, Muslim Social Service Commission, we are developing a proposal on NCDs, community engagement on NCDs. Actually, going to madrasa teachers, going to other mosque leaders, so that we can have them check for NCDs, know their status. And on climate change, we thank you very much. We will be with you for developing a proposal on climate change. We are ready to share, and we are ready to develop the proposal with you. Thank you. And we know that on climate change, we should also embark on community health workers on surveillance, on issues of surveillance. And we thank Minister of Health, Dr. Obuguyu and Dr. Asha Mahita for your suggestions. Your suggestions are well taken. We will be able to implement what you suggested. Thank you.
Thank you very much, and I think we are coming at the end of the panel, but what we have discussed and what the questions we have received are showing that actually we have gotten more from you than what we gave. And in particular, maybe I'll just add a bit on the financing. Dr. Abbas talked about charity. You know, with the Sadaka, when you go, it's our secret in the mosques, but when you look at the contribution, they are really small, which you cannot do very big. So now we have a big focus on Islamic finance, and we have experts on Islamic finance, which are trying to help even addressing issue about crowdfunding, because you see like the efforts in Ilemela, in Mwanza, Kagera, and whatever, they are now taking several years to build one health center. But you can look at other financing to be able to do that faster. So we have engaged an expert on that, which is advising BAKWATA and those on how to raise more money through crowd-source funding, through other Islamic finance channels. And the Universal Health Insurance Bill, which is coming, it's going to add another asset because Islamic insurance has been introduced and has been accepted. So there are people who feel that the normal insurance is a bit like riba, so they would prefer Islamic halal. So that will be available, so it will help on. So the advice we have received, and I think it will improve our forum for next time, because we'll follow on the advices we have given instead of just saying what we have done, we have to go. The strategy was initiated some time ago, but I think it needs to be updated now with the universal health coverage, and we are going to be, we will share it, because BAKWATA, working with the Jamii Bora and Muslim Social Services Commission, will come. So, yeah, I think the NCD data, the problem which I think we should all work, I think people in the ministry are here, our information system, data are collected in the service points in the facility, but the summary report which goes to provide the national data is still based on communicable diseases. So the summaries you get of malaria, TB, whatever, but there's the summary form which gives the information are there in the facility. You can only have researchers to go and dig. So Labda, Dr. Buguyu and Dr. Ash and the others from the ministry, when we review the HMS next, we should have a summary form which collects NCDs so that we can know what is going on. Otherwise, if there is no other questions, I would like to thank you very much for joining us, because if it was only the panelists without you, we would have not achieved anything. And what we had prepared, it appears we got more from. So next time we should engage you in our preparation further. So I hope we have the contacts of the people here, because we would like to share what we have discussed. Also, we put it in a summary form so that you can have it. Can we have contacts of the people who are attending here? Or yeah.
So that is part of networking. We don't take the contacts, but we have to make sure that you do that as part of networking for the conference. Okay. Yeah.
Okay,
yes.
Thank you.
Yeah. So we want to do one thing. We really have to congratulate Dr. Ipuge and the panel for leading this session and for getting more than they gave us. Makofi kwao jamani. Nashukuru sana for an engaging session, truly. And maybe we can have a group photo of the panel as we welcome the next. Just stand there and invite the photographer to have one last photo. Au umeshapiga tayari? Hapo hapo tu. Yeah. Yeah. Quick group photo. Yeah. John, ukumbusho. Okay, wonderful people, smiles. This has been a good panel. That's very good quality and quality conversations. Click for the smile, yes. One last one. Thank you, asanteni sana. Asante sana, mbarikiwe. So if you wish to stay on, we are embarking on the next session for Mikumi, which is going to be the keynote. Keynote 1, improving infectious and non-infectious disease outbreak. This session will go up until the first break, up until the tea break. Hii Keynote 1 ni Keynote 2, hivi ni Keynote 2. Una hakika? Ladies and gentlemen, karibuni Mikumi Hall. We are into Keynote 2, the challenges and opportunities of achieving USC in the ever-changing population dynamics. I will buy us a couple of minutes to allow the whole panel to be here and their moderator in their chair before we can start. Ladies and gentlemen, good morning once again. Thank you so much for the music down. You are in the right place for Keynote 2. We'll start in a moment, just finalizing one small logistics. All right, we're set to go. And once again, welcome to Keynote 2. Don't look at everything that you're seeing on the board. There's been a little, some few changes. So right now, I would like to invite the moderator for this session, Dr. Jessica Oyugi, to take the stage, and then she will do the rest in terms of introducing her panel, at the same time leading the session for us. Dr. Oyugi, you're on the far end, and I'll bring you a mic.
Hello. Thank you very much. Good morning, everyone. It's a pleasure to be here. We've had a couple of changes, but still the meeting theme will remain the same, discussing the challenge and opportunities to achieve HC in ever-changing population dynamics. I would like to begin by calling my colleague from UNFPA, Melissa McNeil-Barrett, who is here. Melissa McNeil-Barrett is the Deputy Representative of UNFPA here in Tanzania, bringing over 18 years of extensive experience in program leadership and management, with a background that involves serving as a regional program specialist and UNFPA Assistant Representative in Jamaica, as well as contributing to UNDP initiatives here and elsewhere. Melissa's expertise in advancing women's economic opportunities, development communication, and program oversight makes her a valuable asset in promoting adolescent health and well-being in her current position. Thank you, Melissa. I believe we have a different World Bank representative. Mariam Ali, are you here? Okay, I do not see Mariam Ali. Perhaps she will be joining us in a moment. Maybe now I could introduce Professor Sayoki Mfinanga from NIMRI. Professor will be discussing some of the burden of NCDs alongside other infectious diseases. In addition to his role at NIMRI, has joint faculty appointments at University of Liverpool, and we're very welcome to have you here with us today. Will that be it? I'll take one last call from anyone from World Bank who's here with us today. Perhaps the MC will inform us. Will we be expecting anybody from the World Bank? Okay, all right. So thanks for being here today. Really, what we'd like to talk about as the theme for the summit is really how we can achieve primary health care on the journey to achieving universal health coverage. We know that the population of Tanzania in the recent census has shown us a significantly increasing young population. We'd like to talk about some of those population dynamics in the setting of UHC. Given that, maybe I can begin with Melissa, if that's okay, just to have a good understanding of what's happened since the population and housing census of 2022, to really understand what strides UNFPA is taking with the government of Tanzania as a partner to ensure a healthy, educated, and young, thriving population. Maybe we can begin with that.
Thank you very much. Good morning. Thank you for having me. It's a pleasure to be here with you this morning to discuss the issue of population dynamics
and the implications for health, and in particular, universal health coverage. To pick up on the question that Dr. just asked, one of the reasons why we look at the issue of population dynamics is because it talks about the ways in which populations change over time, right? So we're talking about things like population growth, things about age structure, population composition, and the geographical distribution. And we know that those elements are important because they have implications for planning, they have implications for policy making, and ultimately in terms of the country's economy, right? In the context of Tanzania, the immediate factors that we will look at today are around fertility, mortality, and migration, but specifically on the issue of fertility as a key factor for changes in population structure. In the context of Tanzania, as you know, there is a high fertility rate, right? And while it has declined over the years, currently we have 4.8 children per woman, and it goes as high as 5.5 children per woman in rural areas. So Tanzania has a high fertility rate. And one of the consequences of that high fertility rate is that the population grows at a relatively rapid pace. So in the context of Tanzania, the population growth grows at a rate of 3.2% annually, which is more than twice the global average. As the doctor just said, in the recent population and housing census, the population of Tanzania is now placed at 61.7 million. And at the current pace of growth, I just mentioned that it grows at 3.2% annually. What it means is that the population of Tanzania is expected to double in 22 years. And in fact, there are 8 countries in the world that are expected to be responsible for more than half of the increase in the global population by 2050. Tanzania is one of those 8 countries. Now, we talked about the high fertility rate, we talk about the rapid population growth, but for UNFPA, one of the most significant features of the Tanzanian population is the fact that there is such a significant youth population, an adolescent and youth population. So what we know is that over 60% of the population is comprised of young people below the age of 24 years old. And therefore, what it means is that with this large youthful population, there is the possibility of achieving what we call a demographic dividend, which is that window of opportunity for economic growth that the country can attain, but only if the investments are made in the health, education, governance, and the economy. So therefore, the point is that with this large population, Tanzania stands to gain significantly in terms of the country's development aspirations, but only if the right investments are made in this adolescent and youth population. Now, the National Development Plan, both for mainland and Zanzibar, both recognize the importance of ensuring that adolescents and young people are healthy, that they are educated, and that they are skilled to take on jobs that are created in the economy. And Vision 2025 as well underscores the importance of investing in the country's human capital resources so that we can harness the demographic dividend. So within the context of Tanzania, as we talked about this large youth population, we talk about the rapid population growth, we talk about the young people and the possibility of young people contributing to Tanzania's development. And therefore, within the context of this conference and the discussions that we're having today, what is the implication in terms of the health sector? Now, we know as well that health is recognized as a key driver of economic development. Healthy people generally are more productive, they have higher average incomes, they spend less on health care, and create savings that are an important source of economic investment. Because of the importance of investing in health, right, and that is key for human capital development and economic development, it is key to invest in health and in particular, universal health coverage. From UNFPA's point of view, we work quite a bit with countries, including with Tanzania, to connect the dots between the importance of population dynamics, and especially those elements I just outlined, fertility, mortality, population growth. But we make the link between population dynamics, reproductive health, human rights, and sustainable development, because they're all connected. And depending on how a country manages those population dynamics, it can therefore determine the country's development trajectory. Now, the evidence also shows us that in order to achieve the sustainable development goals, which we're all aiming to achieve by 2030, the targets for universal health coverage, particularly around reducing maternal mortality, in order for countries to achieve that goal, they must prioritize the core package of sexual and reproductive health services and essential supplies. So sexual and reproductive health, for example, helps in the prevention of teenage pregnancies, in the prevention of HIV infections, right? And so these are elements that when we talk about young people, if we look at teenage pregnancies, about 30% of young people drop out of school due to teenage pregnancy. What that means, or adolescent girls, that if they don't continue in that education, it has implications for their ability to earn in the future generally, and it usually impacts their ability to contribute productively to the economy. So sexual and reproductive health as a part of that health package is absolutely critical, and ensuring access to and utilization of quality sexual and reproductive health services, particularly for adolescents and young people, essential to achieving universal health coverage. When sexual and reproductive health needs are not met, particularly for young people, then it compromises their ability to transition successfully to adolescence and adulthood. So within that context and that picture that I'm outlining now, with this large population in Tanzania, this large youthful population, what actions do we need to take to ensure that these people are equipped to meaningfully contribute to the development of the country, and what is the role of the health sector in ensuring that Tanzania realizes its human capital? And you will recall in July, there was the Africa Human Capital Health Summit right here in this very convention center. And Her Excellency, Honorable President Dr. Samia Suluhu Hassan said it, that there is no better time to deliberate on the human capital issue than now. She said we must set clear priorities in family planning and sexual and reproductive health education among the young people. End of quote. So universal health coverage for all ages cannot be achieved without reaching this large adolescent and youth population. In order, therefore, for us to transform and to make significant progress where UHC is concerned, we have to transform how health systems respond to the health needs of the population, but particularly the health needs of this large population of adolescents and youth. Because we know that health services play an important role in reducing preventable poor health outcomes and in supporting young people, as I mentioned, to transition into healthy adulthood. So in closing, in terms of the key messages that I would want us to take away from this brief overview, it's one, the importance of population dynamics, including population growth, including fertility rates, and in the context of Tanzania, how that has shaped this large youthful population. And therefore, the message is, if we are to effectively uphold the human right to quality health services, including sexual and reproductive health, adolescents and young people must be central in the discussion around universal health coverage, particularly those adolescents and young people who are most vulnerable. We need to also place emphasis on poor, those who are poor and in communities where population growth and fertility is very high, and therefore we need to look at, in terms of UHC and SRHR coverage, we need to look at what are the groups that are most in need, what essential services do they need to receive, and what provisions can we use to prevent financial hardship due to healthcare costs. And finally, what it means for us within the context of this population dynamic and this feature of this large youthful population is that policymakers and the health system in general must adapt to this demographic, right? And migration patterns. I haven't touched on migration because we don't have the time, but we also know that migration and urbanization is significant in the context of Tanzania. Dar es Salaam is slotted to be a mega city by 2050, meaning that it will have more than 10 million people. What does that mean in terms of how we plan for healthcare for this 10 million, which will include significant young people? And so those are some of the elements that we need to consider. The fact that at the center of ensuring that UHC remains accessible, equitable, and sustainable, we must ensure that we're investing in the health, well-being, education, and skills of our young people in particular in order to contribute to Tanzania's development aspirations. Thank you.
Thank you very much. You've said a lot of very inspiring comments that we are reflecting on. Before I move to Professor, I just have a couple of questions to follow on to what you've said. An incredible statistic, really, that more than 60% of the population is less than the age of 24. Curious your thoughts on how to integrate some of the family planning packages you've spoken about that Mama Samia addressed during the human capital development engagement earlier. And what does it mean in terms of realizing UHC to be sure that where we are providing primary healthcare services, we are offering integrated packages? Can you comment a little bit on that?
Thank you. And I think that actually speaks to, I was watching the time, but certainly in terms of the work that UNFPA is doing here in collaboration with the government and people of Tanzania is working with the health sector in particular to ensure that healthcare providers are equipped with the information, the knowledge, the services, and the supplies to deliver healthcare services to young people, including family planning. But in Tanzania and in countries, there are challenges and barriers that young people do face in terms of accessing these services. But we're happy to see progress has been made. And so what we do is we work very closely with the health sector, with the education sector as well, through looking at comprehensive life skills education for young people that allows them to equip them to make decisions around accessing services. But it's an integrated approach, it's a multi-sectoral approach, working with the healthcare providers, with the education sector, with the protection sector, because also the issue of gender is critical. Because one of the things I didn't mention, but in terms of adolescent pregnancy, there's also a link with child marriage, which we have high levels. So in terms of an integrated approach, it works with multiple sectors to ensure that family planning information, services, and also supplies are available so that the population can access these supplies and these services. We also work at the policy level to ensure that there is an enabling policy environment that will allow young people to access this information and these services. And so, between that enabling environment at policy level, in terms of supplies, to ensure that the services are available. And the other key element is that demand generation. So working with young people themselves to ensure that they are equipped and that they have the autonomy to access those services, which can help them to prevent, as I mentioned, early pregnancies, sexual and reproductive health, ill outcomes. And therefore, we emphasize the importance of ensuring that those sexual and reproductive health services are a part of universal health coverage and that package of services that will empower young people and that will help them to transition successfully into adulthood.
Thank you very much. I think we'll come back to you again, but now we'll move on to Professor. As we talk about population dynamics and the rapidly growing population, urbanization as well, we know that lifestyle choices have also changed. We know that we're seeing an increasing number of non-communicable diseases. This sits on the, on the foundation of more typical infectious diseases that Tanzania has seen. And many people refer to these NCDs that are upcoming as a new epidemic. So when you think about this growing population, this significant population, you said by 2050 of 10 million just in a mega city of Dar es Salaam, what does that mean, Professor, in terms of our understanding and awareness of non-communicable diseases? And what do we need to do to ensure that we achieve universal health coverage, not just from mitigating infectious diseases, but ensuring the right response to non-communicable diseases?
Thank you so much for your very interesting question. This is a challenging topic, and in tackling non-communicable diseases and the double burden, I call it double burden because you have communicable and non-communicable diseases. We must prioritize prevention, education, and accessible health care for all. Universal coverage, as my colleague was talking about, especially considering that 80% of 36 million deaths globally, and 98% of HIV deaths globally are happening in the developing country. So it's a huge problem that needs attention. In early 2000, the NCD in terms of burden using DALI were ranked, and they were ranked low in early 2000. But it is projected that by 2030, they will be ranking top. Already, they are top. Things like depression, cardiovascular diseases, hypertension, injuries, and diabetes, they're becoming a major problem in our society. So, and our system, health system, is well equipped with communicable diseases. We are very good. I was talking earlier today, if you ask me about how many people living with HIV and AIDS, how many TB, I give you a figure right away. But ask me about diabetes, hypertension, it's an issue. And it is the one that is killing people now, you see? In developing countries, let's talk a bit about a few of them, like hypertension. In developing country, hypertension, the prevalence of hypertension varies. It's about 30%. It varies from country to country. It's about 30%. In most countries in Africa, now it's more than 30. Some have even 50%. So you can see that this is a really big issue. Let's talk about diabetes a bit. First, we noted progress which was made by HIV program, which now they have reduced mortality. The mortality in Africa is like 500,000. And more than 65 are accessing treatment, everything at the facility. In contrast, when you talk about diabetes and hypertension and the others, I'm using diabetes and hypertension, it's very common, but again, diabetes and hypertension is risky for cardiovascular and the other communicable diseases as well. More than 100 million in Africa, right? And those who are accessing service varies, of course, from country to country, 5 to 20%. Think about it. And only less than 10% are controlled if you talk about diabetes and hypertension. So I think this is a huge thing that we really need to rethink. Let's come to East Africa. With limited data and research, we have figures that they are contributing up to 30% to 40% of all mortality, of all deaths that are happening in East Africa. When you look at the trend for like 30 years, from 2000 to 2030, we see the increasing trend for the NCDs and the decreasing trend for communicable diseases, including HIV and the TB and malaria as well. So you can see the picture is changing, but we are still with very strong health system for communicable diseases. Let's discuss a little bit about the burden of a few of them, like cancer in Tanzania. I took it from the National Cancer Control Strategy, that cancer ranked 5th in causes of death for adult men, and 2nd for adult women. Leading cancer are cervical, Kaposi sarcoma, and prostate. So we have issues that we need to focus on. The STEP survey, which is a national representation, this was done, they are repeating another one now, but it shows the alarming prevalence of risk factor for NCDs. 26% of Tanzanians had raised blood pressure, 11% impaired fasting glycemia, 9% raised fasting blood glucose, with, of course, a little bit variation between male and female. But we know with NCD, the good news with NCD is that 80% of the 4 major NCDs can be prevented by lifestyle. 40% of cancer can be prevented by lifestyle. And therefore, we have like 4 main risk factors that are contributing to increase in NCDs. Physical inactivity, harmful alcohol consumption, unhealthy diet, tobacco use, and these are escalated by the transitions, three transitions: epidemiological, demographic, you are talking about demographic, and nutritional transitions. So those are the things that we need to focus in order to change the situation. Coming to the traditional risk factors for NCD, as I said, the survey, which is a national representation, the percentages are alarming for the risk, but notably, only about 3% of Tanzanians eat recommended servings of fruit and vegetables. This is a big thing. The other noted issue is high birth of prevalence of sickle cell, which is also another problem that is coming. But with this, you see, the NCD comes with things we call comorbidity or multimorbidity. You see, comorbidity and multimorbidity refer to having multiple conditions in one person. This is also coming up as a problem. And we know with this, the risk of death is very high: hospitalization, high health care utilization cost, reduced quality of life, and treatment complications. So you can see that NCD, they are coming, and we are not prepared. I would like to discuss a bit now the issue of like double burden or comorbidity, taking it from HIV. You see, with HIV, there's factors that are associated with comorbidities. And these are related, they are HIV-related factors, like HIV infection, you get inflammatory markers that are associated with increasing incidence of NCD. But also they are exposed to the traditional risk factors as well. ARV, they have increased their life expectancy, so they live longer, they are exposed to NCDs. And therefore, NCD, you see it killing people living with HIV more than we expected with other opportunistic infection like TB, crypto. I'm coming from TB, I'm an HIV person, but in the last 10 years, I saw that I needed to widen my portfolio into NCDs. And they have frequent cardiovascular risk factors in HIV, including hypertension, lipid profiles, and other risk factors. It's very common. And also the comorbidity or multimorbidity, having one or three conditions in one person, increases with age. But it is more in HIV than in HIV negative counterpart. So you can see the problem that we are going to face. There are surely data from PEFA, from African countries like Mozambique, Namibia, Nigeria, Rwanda, Tanzania, Uganda, Zambia, showing life expectancy of people living with HIV that has increased equal even to the normal population. Cancer related with HIV, we know them: cervical cancer, anal, liver, Kaposi sarcoma, non-Hodgkin lymphoma, and yet we know there are vaccines like hepatitis B virus vaccine, human papilloma virus vaccine. Some country government has included into their programs. And this intervention, if they are really implemented effectively, they can help us deal with that. Cervical cancer gained significant attention in Africa, and therefore countries are trying to tackle cervical cancer by vaccination and things like that. There are means for screening. If you screen them early, they can be treated, things like that. But you need an effective system that you can detect and respond immediately. HIV infection and medication damage kidneys, right? The issue of double burden. And about 30% of people living with HIV, they're having this renal issue, renal insufficiency, and this calls for urgency for public health action in this area. In terms of the double burden, just TB also is not unique. Notably high, you see high angina, mental health disorder, diabetes, and hearing disorder in TB. And the risk of having comorbidity in TB increase as you have like more than 3 conditions in one person. So we have a problem. Through our study, we conducted a study here. We are developing integration model in Tanzania and in Uganda. And we focused only on hypertension, diabetes, HIV infection. The multimorbidity or comorbidity was about 20%. So what's the way forward? There are a lot of documents earlier on in morning session they were talking. There are a lot of documents in shelves at the global level, at the regional and at the national. There are frameworks, action frameworks already. If they are used properly, we can be able to control this. And this document they have, because they originate from WHO country, have also developed this document. And I feel that this WHO tool should enhance surveillance, prevention, implementing best buys in prevention, but also strengthening healthcare services, focusing on primary healthcare system. World Health Assembly endorsed the integration prevention framework because, you know, we have a lot of vertical programs. And this has also, this document exists at the policy level, at the government. But what is lacking is action because of capacity, resources, and limited investment in research, how to do this kind of integration. We conducted a large cluster randomized trial in Tanzania and Uganda, and we were offering a one-roof service for HIV, diabetes, and hypertension. We enrolled about 7,000 participants, and we noted that after 12 months, the retention was very high, more than 90%. The viral suppression was very high. It means there were no adverse effect on HIV system. And this paper, within 3 weeks, is coming from the Lancet, main Lancet, will be published, and many people will read it. So I believe integration can offer solution to this. Other countries that are working with integration include Malawi, Kenya, South Africa, Swaziland, and they are particularly focusing on cervical cancer, diabetes, and hypertension, but scale up to the national level is another challenge because of resources, because of capacity, and we need to focus to see how we can do this. Now, how should we manage this comorbidity or double morbidity things? I believe the model must take care primary health care investment together with health system to have a comprehensive continuum of care with integrated package of health promotion and services. You are talking about family planning and other things. They can be integrated. What you need is the capacity to carry out such an integration model in a very effective way. So effective NCD prevention should include comprehensive strategy across patient pathway. Primary health care plays a central role in integration of health promotion and service, and vital component of primary health care should include advocacy, political commitment should be there, equity, access to care, effective surveillance. And I would like to end by emphasizing that it is essential to strategize policy and mobilize resources to strike the balance between primary and secondary prevention when we deal with this double burden, and focusing on common risk factors for infection and non-communicable. Thank you very much.
Thank you very much, Prof. Thank you. You mentioned a few things, and it's a nice transition to our colleague that's joining us from the World Bank. Just as a quick overview, we've talked about the changing population dynamics in Tanzania, the growing population, the significant youth bulge that we're seeing. In addition, we've discussed issues around this silent killer of NCDs, the burden that's now being placed even on the communicable diseases that we're familiar with, like HIV or malaria that's endemic, and how we must actually pay attention to those preventable diseases through health promotion and outreach and surveillance, as you've mentioned. You did talk about investment and what is the need for capital investment, both financial risk investment from an individual level as well as government's efforts. So I'd like to introduce our third panelist, Mariam Ali from the World Bank. You can give us a quick overview of your work to date, but I think it's a nice transition to think about what does all of this now mean in terms of financing, in terms of how ensuring an appropriate path from primary health care to universal health coverage, what's really needed from an individual perspective as well as from a government perspective to support resilient and sustainable health financing.
Thank you so much. Good morning. Apologies for coming a little bit late. My colleague who was supposed to deliver this note is sick, Anissa, so I volunteered. And this is the cost, coming late, sorry. But better late than never. Yeah. I decided to come because I thought this is a very important topic to discuss. And when I read the snapshot which organizers shared with us, I thought it's not going to be complete, this discussion, if we will not show up. So, as she has rightly said, it's really complementing to what I've just heard, but I believe even from the other speaker. I remember when I joined Ministry of Health 20 years ago, my colleagues, my health economics colleagues in the ministry, they were talking about financing, health financing. It's like blood in the body, in the human body. How important it is, it's like blood. All other systems cannot work without that blood to flow smoothly, yeah? You can have blood, but if it doesn't flow, so there are many other areas where we are supposed, not other, all areas concerning health financing need to be discussed, need to be flexible, need to change, we need to be innovative. When I say health financing areas, it includes resource mobilization, it includes how we pool resources, it includes how we pay for these services. Now, most of the low-income countries, actually, we were asked to discuss about low-income countries, but I also share some experiences in some few countries I know. We most of the time focus on one area. We sometimes, before 90s, we are focusing on only resource mobilization, how to get more funds. If you remember, and if you don't remember, let me remind you, we started with user fees, only user fees. But we didn't really think through how would user fees impact service delivery in the system. After some years, we introduced CHF together with the NHIF. Then we did a lot of other reforms, but lucky enough, we are growing as government, we are growing as individuals. At some point, government decided to do comprehensive health financing strategy, which looks at a health financing spectrum from mobilization to financing. So that's what I'm going to do. Now, what I would like to flag out are just a few challenges of health financing, given that all countries, they aspire to move towards universal health coverage, but at the same time, we have a number of things. But at this point, we are going to discuss about population dynamics. We have urbanization. We have everything you can talk about, which influence whatever we are doing. Now, with population dynamics is, sorry, my colleague who just ended, we have emerging diseases age structure is changing. We live longer. We have a bulging youth population. What does it mean to the health system? It means more resources. It means sustainable resources. Now, the most chronic challenge is weak fiscal space. All low and middle income countries, we have weak fiscal space. What do I mean? We have little money. Governments have little money, just like us individuals in our countries, because we are the ones who are paying taxes. So when you don't have money in the country, it means you are not going to allocate enough resources to the health system. Health care is a luxury good in economics. The more you have money, the more you spend on health care. So low-income countries, we have weak fiscal space. It means we are allocating little resources. Now, we have these double burden diseases, chronic diseases, new technologies. It means cost is going up. Even if we don't have population growth, just these dynamics push and really introduce a lot of forces and frustration in the system. It means we need more money. We have youth now. I remember when I was studying, I think most of us, in our stream, we were only 20 students. Now, 80. It means you need 80 package of youth-friendly services. You get it? How flexible is your financing in the system is? Very inelastic, not that much flexible. So that is one challenge. The second one, I've implied it, high cost. We have new technologies. They are very good, but they are costly. It means more resources required to the sector. People are now educated enough. More people are more educated. They know what they want. They know what they need. So they also introduce a lot of pressure in the system. Because before you go, a doctor tells you what you're supposed to get, but now I say no. I'll go to a private doctor. I'll go to another hospital and discuss with the doctor. Maybe I need this. I don't want ultrasound after every other month. For my pregnant woman, I want every month. That's how it happens. And those are the things involuntarily bringing pressure in the system. We also have unequal distribution. Those are the challenges, financing challenges, unequal distribution of resources. And surprisingly, it's a chronic disease to all low and middle income countries. Our urban areas have they get more resources. Why? We allocated them more human resources. Most of us, we want to stay in Dar es Salaam, we don't know how that impacts the system. It means per capita in those regions is higher than Rungwe, than than Songwe or Katavi. Per capita. It means those people in Songwe, they receive less quality services because one nurse covers 1 million population. Oh, that's just an example. Minister of Health, don't take it very seriously. Just an example. But the proportion is obviously, it's not equal. So that is also because our countries, they focus on equitable allocation of resources. We want to serve more poor people who need the services most. Other challenges, I have many, but I would just like to talk about few. We have experienced, what happened, doctor, in Bukoba, Marburg. In my growing, I didn't hear anything like that. So those are the things. You can't believe how much went to Marburg. Where did we get it? It means we took that money from somewhere else. Is it in the health system? Those are the things which stress. Those are the challenges. Now, those are just few. I have several. Just because of time, let me end there. Those are the shocks. Those are the challenges we are facing. Now, how do we deal with these challenges? There are many ways. You can use financing models. They try. They don't solve the problem 100%. Some countries, they decide to take one model. Some, they do a hybrid. Some countries like UK, they have taken taxation, government tax, only government tax, 100%. But what does it mean? Your salary goes maybe 40%. Yeah? Sometimes we praise them, but we don't know the cost. But other countries like Germany And maybe most of the low-income countries, we have decided to follow Bismarck model. A hybrid, which includes Bismarck model, insurance schemes, and government tax. Now, those are the financing models. When you go for taxation, no problem, 100%, because most of our taxes are already equitable. The more you pay, you earn, the more you pay. So it means those who pay less, who earn less, they pay less, they contribute less, they carry burden less. Yeah? I don't know if I'm, yeah. So that's the best, but that is impossible because of the fiscal weakness which we have. Now with insurance, again, we have a challenge. Most of the low and middle income countries, they have a bulging population of informal sector. Saluni, they get a lot of money, but how do you get them to contribute to the health insurance? Boda, how do you get them? So we always come with the hybrid. Hybrid helps government to finance the poor who cannot pay 100% and to catch formal sector which can pay, and we have a way to catch them. We can just go there direct to your payroll. Easily, one button, 3% off. But how do we get this? This we call them missing middle. This is the headache of all countries. In Tanzania, you have had that bill which went to the parliament last year. It has been dragging. Last week, actually not last week, it was Monday. I was attending a meeting, Nairobi. They're also struggling, introducing social health insurance. The struggle is the missing middle. How do we catch those people? How do we save them? But also, how do we use them to save others? Because we believe in cross-subsidization. Those saloon people, boda, they're not sick, but they can contribute, and our old people who don't work now can benefit. And after 50 years, you boda, you'll also benefit from other bodas. You get it? But now, how do you do it? That is a challenge. I'm trying to put it in a very normal language so that we know what are the challenges and what are the solutions. Now, in Tanzania, in Tanzania, we are struggling with UHI because how do we pay for the poor? Government is supposed to pay for the poor. Where will the government get the money? If you approve the bill, it means that is a legal requirement. A poor person can go to the court and claim government didn't do it and they're supposed to pay. So those are the challenges, and that's why we are coming to hybrid. And many countries of our nature, they start the way we are starting, with the formal sector to get additional resources, because government tax is there, not enough, formal sector, but also paying for the poor, so you add more resources. But there are many other innovative ways of health financing, depending on the country. Most of the Ministry of Finance, I would do the same. They would not like to have earmarked taxes because you are taking away from government coffers. So nowadays we have health bonds. Countries like Cameroon, they have health bond. Rwanda, they have health bond, which helps government. It's a long-term commitment, and it helps to leverage resources from the private sector. And other innovative ways is not only about financing, even investment, using private sector. Government now, if you want to establish a hospital, you need to get money from Ministry of Finance. But if private sector invests on the infrastructure, it means you have leveraged resources. People will get services, but the capital came from private sector. So those are the innovative ways, but government need to be very strong to regulate, to make sure that these private providers, these bonds, they really serve those who need services most. Now, I was also advised, requested briefly on other ways of, we can do this, but other things is through resource allocation. You understand, Tanzania, we are having resource allocation formula. Those are the ways, with the little money you have, how can you efficiently use that money? Yeah? How do you efficiently and effectively use the money? So you can use resource allocation formula, making sure that those regions like Rungwe, like Songwe, they get more resources compared to urban areas where they also have local owned resources. Other methods is need according to need. You assess a country, you assess a region according to their need. But These things, the way we speak, they are easy, but they are not that much easy because we have oh my God, I feel bad. Yeah, because we have many players. I didn't talk about partnership when I was talking about financing models. We have developed partners. All these things, sometimes they distort the system. We have duplications, yeah, wastage of resources. In other areas, I remember I did assessment of nutrition investment in Tanzania. In some areas, there is where the burden is maybe 20%, 2%, investment is 80%. So those so we need to have really, that's why I was saying you need to work on each and every area of health financing, resource mobilization, repooling, and even purchasing. Now with the purchasing, that is the last one. Purchasing is how you pay providers, how you pay. For example, let me give you an example, which you all know, health insurance. They are paying you using fee for service. Fee for service is very good for us, but that has a very negative impact to the system. When you go with a fee for service, just try. Doctor will tell you, I thank you for listening. They'll tell you, you need to do ultrasound, but I think also a chest x-ray. But these medication, these are good for pain, but even these ones, but if you go with another, maybe DRG, payment method, they'll say, no, this is not necessary. Ultrasound, not important. You know, they have these, side effects. So they always accelerate the cost according to the payment method you are using. So the governments need to really work on each and every element of health financing to make sure that we have efficient and effective financing in the health sector, which will lead to UHC. Thank you so much, and apologies for rushing.
I'm going to ask if we have just 5 more minutes. Is it okay? Can we stay for 5 more minutes? I'm looking at, is it all right? 3 minutes. Mariam, thank you so much. Honestly, no apologies needed. I think it's exactly the energy that we required, and it actually brought together the entire discussion because you've raised some really essential questions in terms of how do we create a formula, right, that requires a lot of hybrid innovation to be able to meet the financing mechanism to create sustainable universal health coverage. So thank you for that. I'd like to just take at least one question from the audience so that this can be interactive. I know this is what you've done for us. Forgive me, I'm gonna just go with our gentleman here in the front row for any of the panelists. Yeah.
Thank you for being just to me. My name is Omar Buguyu, Assistant Director for Non-Communicable Disease from Minister of Health. So when we talk of UHC, I know for sure this is the area that is the biggest burden on my portfolio. My question is to Mariam. I know in these modes of financing, always we are copying from what others are doing, but look at Upatu, or to most of our Tanzanians, M-Pesa, Tigo Pesa, we are not familiar with these routine or modern ways of financing or modern ways of social activities. But we've our own ways of creativities, and we are used to it. Mimzaramo, Kigodolo, people will contribute for it because we have our own ways of making people contributing to it. So what are kind of innovation on this financing, which is very typical African or very typical Tanzanians, but could probably assist us on financing for healthcare system? Yes.
I think, sir, can we take one more question and then we'll end there? The gentleman in, I'd like to call on a woman, sorry, forgive me, gender equity. I'm going to go with a woman here.
Thank you. My name is Anit Emmanuel from the University of Dodoma. My question goes to Dr. Grace. Dr. Grace, you have said before that you are dealing with education sectors in the provision of education on non-communicable diseases and communicable diseases. My question is, what are the efforts made in primary schools and higher learning in establishing Earth Club and Earth mentorship rather than depending on school books and curriculums? that could provide a wider education in productive health as well as communicable and non-communicable diseases.
We'll take one more question. Gentleman in blue. Sorry. For anyone that's able to remain afterwards, we can take additional questions.
Thank you so much. I want to ask a question on population dynamics. 30% of the youth, or talk of 60 or 16 million or so, are stunted, 30%. That is population dynamics, okay? If you have 30% of your population stunted in the labor force, okay, they will not be able to achieve universal health coverage. So I think we should have to revisit population dynamics, understand dynamics, and then work on it. Because if you go to population dynamics, our pyramid population has not changed from 1961 up to 1923 in the African region, but the rest of the world has changed. So we are dying as we are dying in 1961. So please, I'll be very happy if you can support us to understand this one. So, coming on health financing, you are going to tax a stunted person with very little IQ, having 1 meal a day, okay? And you will kill this person. This is unethical. This is murder, okay? So I think in terms of opportunities, we are missing opportunities. 2,000 medical doctors on the street, CT scans in regional hospital, no one knows how to use them, billions of money, because doctors can use them, but they are on the streets. And regional hospitals are killing expectant mothers. In Morogoro, twice as much mothers died last year than 2021. And this is in the minister's speech of 2023. Regional hospitals have become a mortuary for maternal cases. So can we fix our system to give us quality care and then see how much financing we need? And please, do not kill the poor in this stunted.
Anodi, I see you, but I think we need to have the panelists respond, and maybe we have a minute at the end. Beginning with, before we get to curriculum and response to NCDs, I'll just have the finance question responded to.
Thank you so much, Dr. Omari, sorry, and sir. Really, the challenge with health financing is most of the time who contribute they're not supposed or not necessarily benefit. That's the difference. Other things, part to everything, I contribute, I'm the one who is benefiting. So that's why it's very easy. People volunteer because of the benefit. But with health financing, we cross-subsidize. That is the biggest challenge. That's why government needs to intervene, because that is not really, it's it is a public good. Government intervention needs to come in. That's why we are talking about innovative financing in the current bill in Tanzania. When we started, we requested the popular mobile tax, which it was introduced. Government said no, but they agreed to introduce for another sector. We are the ones who started requesting that one. But you can just imagine the way population reacted to what was introduced. The other innovative financing which we gave forward, it was tourism. The sector was like, oh, our tourists are not going to be happy. So the challenge with health is that the beneficiary is not the one who is paying. Now, where government is now, they've decided not to go that way. They want to come with government tax for the poor. That's where they are now. We don't know if that's going to sell through because we are still waiting for the parliament. I didn't talk about community health insurance. Those are like Upatu kind. In the world, there is one which has really supported towards UHC. They can do to some extent, like our CHF, ICHF, it can do, but not universal health coverage. So those are the challenges. You need coverage, you choose what you want. You need quality, you choose what you want. Going to the poor, thank you so much. When we talk about poor, we don't talk about poor who have certain characteristics. We talk about all poor people, including stunted. By the way, literature tells us stunted people, they earn less, I think 30% or 40% compared to their colleagues. So they are those poor people. So they're going to be covered. But it's not really a proud thing to talk about covering those people. How do we take them out of that? Because stunting, people can get out of that. How do we, and that's why this year we had Human Capital Summit to see how collectively we can work. And the challenge is, it's not only health sector with stunting, you know it very well. We have education, we have our sector, we have many other sectors. And our Minister of Finance has agreed, at least to the bank, he wrote that to make sure that multi-sectoral approach towards human capital, which includes stunting, is going to take place in Tanzania.
Thank you.
Right, no, I think the point on stunting was mentioned, but I think the issue is in terms of addressing some of these challenges around young people. I think we're now at a pivotal time in the history of Tanzania, in the sense that there are discussions now ongoing about Vision 2050 and how do you plan for this population and this large population of young people. And so for me, I think the crux of the matter is, as we look forward and we have this large number of young people, the population growth continues to increase. There's a concern about numbers, right? And therefore the quantity. And while that is valid, I think the focus should be on the quality of the population. So how do we ensure that with this population growth and with this large groundswell of young people, you talked about the pyramid, this broad-based pyramid of young people, how do we ensure that we have a quality population where we're investing in health? Primarily, we talk about health because of the context that we're in, but we know also importance of investing in education, in investing in governance, in investing in employment opportunities, in investing in skills, which come through skills both in school and out of school, but to ensure that this population of young people is efficiently equipped to contribute to the development of Tanzania. And I think that is important. And health, especially universal health coverage, and sexual and reproductive health, which is an area that is close to our heart, is critical in empowering and enabling young people to be able to achieve their full potential and to contribute to the development aspirations of the country.
Thank you all so much. Really very appreciated. I think just to summarize, we can see that this is a very multifaceted conversation, that universal health coverage, although keeps that focus on health, is actually much more about all of the social determinants of health and how we can contribute to ensuring sustainable financing through innovation, how we can ensure that we're keeping an eye on the growing population, both the aging population and the young population, ensure that education is not just in the schools, but incorporates what's happening at a community level, because as the doctor has said, there's a certain amount of innovation and empowerment that can happen by really supporting and giving agency to communities to be able to impact what's happening for greater quality universal health coverage. So thank you so much. I apologize for being a little bit late. It was a great conversation. We really welcome you for bringing us around full circle in terms of what the impact is, not just on NCDs that are coming forward, the population dynamics, but how do we bring this together in terms of innovative, sustainable financing. Thank you all so much.
Thank you so much, Dr. Oyugi and your panel. I want us to just move back to the main sitting, and I want us to, for the next 5 minutes, to bear with us as I welcome Dr. Ibrahim Selem to lead us to a skill set session which the Tanzania Health Summit has put forward for us. Imagine you are sitting at a dinner table with your family, either your friend, and someone chokes. How do you go about it? And for that, I welcome Dr. Selem to give us about 5 to 6 minutes of training how to manage a choking person. Just push it all the way forward.
Hello, good morning. I won't take much of your time. I'll just use like 10 minutes. Just a short practical session on how to help a person who's choking. Sawa, kwa tafanya iwe fupi sana. it's a practical thingy. Kwa hiyo ukibona mtu amepata choking, amekwama na chakula au amekamwa na chakula, unamsaidiaje? Kwa hiyo choking could be mild or severe, as in complete obstruction. Sawa. Angalau yule ambaye ana partial choking, anakuwa ana cough, ana a little bit of breathing, lakini ambaye ana complete choke hawezi kufanya chochote, cannot talk, hawezi kabisa kuhema. Tamuona tu amestrangulate trying to take it out. Umeona? Kwa hiyo mtu ambaye amepata mild choking, you can just try kujaribu kumsaidia, encourage the person to just choke, to just cough and cough and cough. So, let's say this lady here is having a little bit of choking. Kwa hiyo unaweza ukajaribu kumbend kidogo, encourage to cough. Kwa hiyo mara nyingi kama ni just partial, if it's just partial obstruction, this coughing will help something to come out. Ndio. Lakini if it's complete obstruction, unaweza kumuona mtu tayari ana strangulate the neck, ametoa macho, the eyes are just bulging out, cannot speak, cannot cough, cannot breathe, sometimes tearing. Namuona kama this person is in distress, kwa hiyo this person cannot breathe. Kwa hiyo you have to intervene immediately. Mara nyingi kwenye hizi first aid unajaribu kumwambia kwamba you are trying to help, kwa sababu this is very crucial, just I'm trying to help you, kwa sababu tayari yuko in distress. Kwa hiyo this can just actually calm na yeye kukupa cooperation, kwa sababu actually unahitaji pia cooperation kutoka kwake. Kwa hiyo I'm Dr. Flani, I'm this and that, I'm just trying to help. Are you choking? I'm trying to help you. Kwa hiyo normally they can't speak, but they might give you a nod. Umeona? Kwa hiyo this can actually give you the cooperation that you need. Si ndio? Kwa hiyo next ni kwamba you can't see what's choking na kimekaa direction gani. Kwa hiyo actually what we want to do is just maneuvering and trying to just get it out. Si ndio? Kwa hiyo what we're going to do is let's say this person just there. First thing we're going to do is try to support. Sawa? And then Jabir, everyone. Yeah, kwa hiyo first thing is you try to give back blows. Just locate the scapula and then just in the middle here, try to use your heel. Then you just give 5 blows. Ziwe sharp as possible. Alright? You just unajua. Umeona? Kwa hiyo you just do them 5 times, and then kama hakijatoka kitu, that means you go for what we call Heimlich maneuver. Kwa hiyo unaweka first, you locate the navel, and then una katikati hapa. Umeona? Yes. And then you just stand behind the person, because this person can fall unconscious anytime. Kwa hiyo if you're not creating a support, kama alivyoweka ndugu yangu Jabir pale, utaanguka naye, sababu wengine wanakuwa ni a bit heavy, si ndio? Kwa hiyo just unarudi nyuma kidogo, you create the support, kwa sababu hata sababu hakuna oxygen unaokwenda, kwa hiyo this person can collapse anytime, sio? Kwa hiyo just hiyo ile hata akianguka unaweza ukashuka naye taratibu. Lakini in the meantime, because that's not happening now, you try to create these abdominal thrusts, sio? Then it's super painful but super effective. Kwa hiyo just give them like 5 of them. And then kama bado, you go back to your back blows, and then the thrust, blows, thrust. So one of the two things might happen. If it goes out, perfect. But if it doesn't, that means this person will just collapse. Kwa hiyo unashuka naye chini, and then you start CPR. So, okay? Because this can happen anytime. Well, inaweza ikawa nyumbani, inaweza ikawa kazini, anywhere this can happen. Kwa watoto wetu it happens. Sisi tuliokulia Afrika, we know how we feed our children. Unaziba pua hivi, unalisha, umeona? The baby has two choices. Umeona? Either ameze au afe, sio? Sasa unajua hapa chini, if the baby starts crying, that means unajua there's this epiglottis tends to just play around. If you can't talk and eat at the same time, you can't cry and eat at the same time. So mara nyingi vinaenda on the side kwenye airway. Kwa hiyo we are choking our babies. So if it happens kwa watoto, we do the same thing. Lakini you can't do the thrust, especially for small babies. Kwa hiyo we tend to use fingers. We do the same thing like in using fingers, and then you just turn the baby. Shuka chini kidogo, mweke kwenye ili, kwa sababu unajua ukimweka hapa unaweza ukafanya hivi, katoto nao kakasepa, kakaruka huko, kakaumiza. Kwa hiyo distance, shorten the distance, jaribu kushuka chini kidogo, do the same thing lakini angalau ukiwa chini. Just minimize the height. Do the same thing. Sasa kwa watoto it's very crucial, hata if you see something is out, just take that baby to the hospital. Sawa? Kwa sababu these are things ambazo hazikutakiwa kwenda kwenye hewa. Kwa hiyo ni source of infection, ni pneumonia. Kwa hiyo unaweza ukawa umeondoa obstruction lakini baadaye umebakisha mtoto na infection. Same goes to the adult kama huyu. Kama ukifanikiwa kutoa kwa back blows, that's better. Lakini if you go to the Heimlich maneuver, ukiwa ushafanya abdominal thrust, it's far better huyu mtu baadaye aende kwenye healthcare. Sawa? Is that clear jamani? Thank you.
Thank you so much, Dr. Mselem, TMHS and your team kwa kutupa hiyo mbinu ya kuweza kumsaidia a choking person. So, rush for your break, grab your coffee, and if you are coming to the next session ya water aid into Mikumi, tunakaribisha sana. Just remember that you have to show your badge kwenye coffee. You have like a couple of minutes. We apologize for all the time, but all sessions have been great. Nawashukuru sana, nawakaribisha tena Mikumi saa 4:30. Couple of minutes from now. Next up is the water aid session. Hello? Because we ate a little bit of time, all the halls ate a little bit of time into break. So we are adding 10 more minutes. We'll start at around 40, 10:40. And that's the same time we'll push towards lunch. Kwa hiyo, tumtuombe radhi kidogo, ni kwa sababu all the sessions have been running over time. Ila mliopo kama mko tayari, tunawakaribisha muendelee kutusubiria. Asanteni sana.
Take my whole life too. If I can fall in love with like a river flows surely to the sea. Darling, so it goes. Some things are meant to be. Take my hand, take my whole life too. If I can fall in love with you. If I can fall in love with you.
Hello again. We are just about to start. Just finalizing one logistic for the PowerPoint, and then I will hand it over to Dr. Happiness to get us started. And that's the signal I was waiting. So, Dr. Happiness, over to you. Just remember that whoever is making the presentation to say next, so that the gentleman at the back can remember to move the slides. Karibuni.
Okay, I will start right away, and I'd like to greet you all. Good morning, everyone. My name is Happiness Willibrod. I work with Water Aid Tanzania as the head of programs. I'm happy to be with you all here today as we're discussing an important point of why WASH is a vital subject in universal health coverage. And before I invite the panelists, I would like to take you a little bit through the background of WASH and its importance in health, and as well as we link it with universal health coverage. Next, please. So as an introduction, Water Aid Tanzania has been working in the country for over 40 years now. And as an operational office of the UK within East Africa. And at the moment, Water Aid is implementing its new strategy with two main aims. The first one, aiming at attaining sustainable, inclusive, and safe services in the target geographical areas. And the second one is really looking at prioritizing WASH across the health sector to improve public health. And the second one is what is linked to the discussion that we are going to have today. Next, please. So I wanted us to look at a bit of a background of WASH and universal health coverage. Globally, the data show that the basic hygiene services are unavailable in almost 50% of the healthcare facilities. And the topic around universal health coverage with WASH is really picking from the World Health Assembly resolutions, which were adopted back in 2019. And they are stressing on the fundamental importance of adequate WASH services in achieving universal health coverage. And if we look at this global perspective of WASH in relation to UHC, it gives an emphasis on the crucial role of clean water, sanitation, and hygiene in promoting health. And as we promote health, we end up in achieving, or we contribute in the achievement of universal health coverage. Next, please. A little background, a little background about the situation in Tanzania, and these are data collected from different studies, some done internally by WaterAid, but also, like the picture is globally, also our facilities, like over half of them, they lack piped water supply. And we all agree that at least when we have piped water, we are a bit sure of the kind of water that we are supplying to the healthcare facilities. In those that are connected with piped water, up to two-thirds, they report irregular supply. And this situation is really affecting the healthcare workers and patients. And if we speak patients, it is mainly affecting women and children, especially during labor and delivery. And only two-thirds of the healthcare facilities provide patients with access to toilets, and 44% and 42% respectively of healthcare facilities, consultation rooms and delivery rooms, they lack functioning hand washing facilities. We're still observing limited menstrual hygiene services on the facilities for female patients as well as staffs, and as well as the adolescent girls who are trying to access services from these healthcare facilities, but also the accessibility of the facilities for the people with disabilities is still questionable, not that much scaled up in the country. But we understand, despite of all these gaps, we still don't want people who are going to the healthcare facilities to get service to leave the facilities while they are sicker than when they entered the healthcare facilities. And if we are having poor WASH standards or at the healthcare facilities, it is likely that people may contact diseases at those areas. And if that happens, it even kind of discourages them accessing services in the next time. If we link WASH and reducing the healthcare cost and economic productivity, it is proved that investments in WASH infrastructure can lead to cost saving in the healthcare sector. And if we treat diseases caused by poor WASH condition, we save a significant amount of money. It is highly expensive to treat the diseases related to WASH. And by improving this access to clean water and sanitation, the healthcare system can redirect those resources toward other priorities. From one of the UNICEF reviews, it is seen that the estimate of 70% of spending that are kind of allocated for healthcare, they are directed to deal with preventable WASH-related diseases, and we know we have a lot of them. So you can see if this is the number, or if there's any other review, it will not be not far from this. We still need to look at it differently to make sure that we are having savings that can go and service other areas. Also, when we have people who are healthy and not suffering from waterborne diseases or illnesses, they can be more economically active, and this can ultimately support mobilization of resources to direct into UHC from the individual level to the government level. And we see the pivotal role of poverty reduction and economic growth if linked with improved WASH services at different levels. Next slide, sorry. No, the previous one? Yeah. From the recent reports by World Bank, if we also look at the economic lens in relation to WASH, it is seen that the country is losing almost 5.6 trillion shillings annually, which is equivalent to 3.2% of the GDP, due to poor access of clean water and sanitation facilities. And it is even said that this estimate may still be on the lower side because there are some aspects which were not looked upon during this analysis. So this is a significant amount that can also be redirected to another areas. Next slide. But we look also at WASH in the angle of disease prevention, and it is proved that access to clean water and sanitation facilities is essential for preventing waterborne diseases such as cholera and diarrhea. For the diarrhea-related diseases, just by improving WASH, we get up to 36% reduction. And we see a good trend in the regions or areas with improved WASH infrastructures and services, where the incidences of reported waterborne diseases is kind of significantly reducing. At the country level also, the review shows that 31,000 Tanzanians die each year due to poor WASH services. And this is 10.3% of all premature deaths that can be prevented just by improving WASH. And we know if we prevent death, it means we get more people doing other economic activities, and in cities also impacting our economic growth as well. And proper sanitation also reduces diarrhea by 36%. I've already said that. If we look at an important angle of maternal and child health, we're also seeing access of clean water and sanitation facilities during childbirth and postpartum, how highly they are contributing to safer deliveries and better postnatal health outcomes. And we know if we get safer deliveries and safer postnatal health outcomes, it means even speaking about issues like sepsis, for both maternal and neonatal sepsis, we get a significant reduction. And the lack of availability of safe WASH facilities during childbirth, they contribute significantly to poor health outcomes to both mothers and child. And newborn in low-income countries are at higher risk of morbidity and mortality from sepsis, and this includes also the women who are delivering the facilities with poor WASH services, especially when we come to the facilities that are providing EMOC services, the operative ones. But also, by just having WASH, sepsis can be preventable, averting up to 1.4 million maternal and neonatal deaths each year. So we see how important also this aspect is. For the service delivery, the standards of water sanitation and hygiene management are crucial components, as well as said previously, for patient satisfaction and quality of care at the healthcare facilities. They do increase the healthcare seeking behaviors, but also they increase comfortability of the healthcare providers if they're providing services to patients. And WASH investment in healthcare facilities do enhance patient health outcomes, lower healthcare associated infection, and they boost the confidence and morale of both patients and healthcare workers. We know the country has not been quiet about this. There are several initiatives that are going. The importance is highly known. There are different avenues that are working, making sure that we are attaining sustainable WASH services for our communities and Tanzanians. And at the national level, one among others that I'm just mentioning here, we will also see during the panel discussion other measures that have been taken. But we have the WASH in healthcare facilities guidelines which are already endorsed, and it is a remarkable achievement in the health sector. And these guidelines were prepared and realized through the coalition building and collaboration between partners and the government, and all of them looking forward to make sure that we are attaining sustainable wash and averting the mortalities, morbidities, and the economic impact that are coming out of poor wash services. So it is one of the noted success in the wash sector. We are going to hear about others from the Ministry of Health representative as we go into the presentations from the panelists. So as we are going to this presentation or the panel discussion, we are still emphasizing on how equitable and universal health coverage access cannot be achieved without specific measures in WASH policy and programming to ensure that the healthcare settings are conducive enough for safe delivery and use of services to healthcare workers and patients respectively. We believe that investment in WASH in healthcare facilities is of paramount importance, and we wish to see rising standards beyond basic service levels and commit to specific actions to address specific WASH needs, especially for women and the most vulnerable population. We are looking differently at the lens of girls and young women and women at all in assessing safe water, sanitation, and hygiene services as a critical component to sexual and reproductive health and gender equality. Just from the few data, we see that a girl can miss 2 to 3 days cycle in a month, and in a year they can miss up to 40 days per year, being out of school just because of missing the WASH services, and 17% out of school in the due period. And this is the population that we want to rise to make sure that they are making a positive impact in our economic as a country, as in turn contributing to the attainment of universal health coverage. So we know we have had several discussions from different panels and excellent suggestions that are coming out to improve universal health coverage, but less of which are discussing issues on WASH, which we wish also to be taken forward and looked upon in a different angle. And after the debates, who knows where the obligations or future obligation will be carried? Is it at the health facilities, at the ministry level, at the partner level, or where exactly are we going to make sure that we are taking forward these steps? So as we go into this important discussion, I would like to just quote one statement from WHO, which says a healthcare facility is lacking water, sanitation, and hygiene is not a healthcare facility, meaning it is not a safe environment for either the provider or the patients who are seeking care from that place. So next in the session, as we discuss more or further dwell into this matter, I would like to welcome our panel speakers who are really going to give us a hands-on experience, but as well kind of allude more on the interventions or initiatives that are going on at the national level, and how are we looking on WASH, and what is the call that we really need to look at in order to make sure that this is becoming a standing agenda as we speak about attainment of universal health coverage. So I will welcome my first speaker, Anita Mganga. Karibu, Anita. Anita is a nurse midwife, and with over 9 years experience. She is currently working at Isanga Dispensary located in Bahi, Dodoma. Anita is passionate about her job as a midwife and is always excited to serve her patients with love and care. She's a champion of better services in healthcare facilities, and frequently she airs her voice on communities and leaders, and this has caught the media attention as of late. Karibu, Anita. And our second speaker is Dr. Ezekiel Mbao. Karibu, Dr. Ezekiel. Dr. Ezekiel Mbao is the president of TANA, and as of now, he is serving as a lecturer and holding the position of Dean of Faculty of Nursing at Herbert Kairuki Memorial University. With a career spanning over 13 years, he possesses extensive expertise in teaching, research, and consulting. His primary research areas encompass adolescent health, mental health, maternal health, and child health care. Karibu daktari. And I would also like to welcome our guru, Engineer Herbert Kashila, who has been in the WASH sector for over 30 years. He is the founder of Shahidi wa Maji, a not-for-profit organization dedicated to support a fair water future for every Tanzanian. He has over 30 years supporting development of water and sanitation sector in Tanzania and in East Africa. He is currently the chair of water and environmental boards, including a chair of WASH Networks TowersNet and Water Resources Catchment Authority for Lake Rukwa Basin Water Board in Tanzania. He is advisor to African Network on Water and Sanitation. Karibu sana, engineer. And lastly but not least, I would like to welcome our representative from the Ministry of Health, Mr. Anitike Mwakitalima. Mr. Anitike Mwakitalima is the head of Food, Water and Environmental Sanitation, Environmental Health and Sanitation section from the Department of Preventive Health Services from the Ministry of Health. He has been working as a National Sanitation Campaign Coordinator since its first phase and was launched in 2012 and lasted in 2015. So he is the champion on that campaign. He made sure that it was taken forward and it was implemented successfully. The National Sanitation Campaign among its intervention areas is WASH in healthcare facilities, of which the government have invested a lot to support improvement of WASH infrastructure. Karibuni sana. So I will shift to the panel discussion and continuing to beg your attention. Thank you very much. Okay, we'll start our discussion and we'd like to get our very first reflection from the grassroots level, and this is coming from Anita, who is the healthcare worker. Really, on daily basis, she's engaged in service provision, and for 9 years, she has a lot of experience when it comes to service delivery and how is it linked with WASH. So Anita, as a healthcare worker, can you share with us the experience of working in healthcare facilities in the context where WASH services were limited, and what have been the consequences to you and your patients, and how does this make you feel, and what actions did you take to improve the situation? Karibu.
Habari. Naomba kwenda moja kwa moja kwenye jambo unalopaswa kuzungumzia. Mimi kama mtu wa huduma nimepitia wakati mgumu katika ufanyaji kazi, hasa katika mazingira ambayo nilikwenda kufanya kazi. Palikuwa hakuna chanzo sahihi cha maji katika kijiji, lakini hata katika mazingira yale ya kazini hapakuwa na maji ya uhakika. Hivyo ikapelekea kuniweka katika wakati mgumu katika ufanyaji kazi. Sambamba na maji pia, hata ile miundombinu kama shimo la kutupa placenta hatukuwa nalo, shimo zuri ambalo pia ilikuwa inanipa wakati mgumu unapomzalisha mama kutupa zile placenta. Lakini pia hata shimo ambalo tunatumia kuchomea taka kwa wakati huo halikuwa katika hali nzuri, na vyoo ambavyo tulikuwa navyo kilikuwa ni choo kimoja ambacho tunategemea kutumia wote wagonjwa na mimi mtu wa huduma. Kwa mazingira kwa ujumla hayakuwa rafiki, na kitu ambacho kilikuwa kinanipa msongo wa mawazo na kutofurahia mazingira kwa ujumla. Na tumeenda katika mazingira hayo kwa muda mrefu tukijaribu kutumia mazingira kama yalivyo, huku tukijitahidi kutengeneza namna ambayo itatufanya tuwe comfortable. Na kwa bahati nzuri katika miaka yote tulikuwa tunafanya kazi, mwaka 2020 ndipo tukapata mdau ambaye alitusaidia kupata maji ya uhakika, japokuwa sasa hayakuingia ndani ya kituo, yakiwa tu nje na mpaka leo yapo nje. Kwa hiyo angalau wametupunguzia ile adha ambayo tulikuwa tunaipata mwanzo, hususan katika swala la maji. Tulikuwa tunatuma mtu kwenda mbali zaidi kama kilomita 3 hivi, anafuata na baskeli au pikipiki atuletee, lakini ilikuwa inatugharimu kwa sababu hatakuwa na fungu ambalo kituo kinalo kwamba litatumika kwa ajili ya maji. Kwa hiyo tulikuwa tunatumia fedha zetu, na wakati mwingine ilitulazimu kuagiza ndugu waweze kuja na maji mara wanapokuja na mgonjwa, hasa mjamzito. Na kwa bahati mbaya sana maji ambayo tulikuwa tunaagiza ndugu yalikuwa ni yale ambayo ni ya visima, kwa sababu hatuna chanzo kizuri cha maji kwa wakati huo. Kwa hiyo yalikuwa ni maji ya kisima ambayo hata rangi yake haikuwa comfortable kwa matumizi, na ukizingatia tunafahamu katika sehemu za kutoa huduma za afya maji yanahitajika kwa kazi nyingi. Tunanawa mikono, tunaoshea vifaa kwa ajili ya matumizi, na kama unapoenda kuosha mtu kidonda, tunapoenda kumzalisha mama, tunatumia vifaa ambavyo vinatakiwa vioshwe ndivyo vichemshwe kwa ajili ya matumizi ya mgonjwa mwingine. Sasa yale maji hayakuwa mazuri, lakini ndio maji ambayo tulikuwa nayo na ilazimu tuyatumie. Kwa hiyo nimepitia kipindi hicho, ila mwaka 2021 tukapata hayo maji ambayo ni masafi ya kisima ambacho kimechimbwa kisasa na yamewekewa dawa, lakini changamoto ni kwamba hayako ndani. Kwa hiyo bado hatuna hata zile sinki za kunawia zenye ubora. Asante.
Asante sana Anita kwa that reflection. Na kutoka kwako labda ningependa kwenda moja kwa moja kwa Dr. Mbao ambaye amekuwa katika government level. Dr. Mbao, I understand Tana has been in the forefront on taking forward issues around WASH, and this is really meant to address issues like the one that Anita has just alluded to, make sure that the people who are working there are having also the comfortable environment. And I will say this has been one of your standing agenda. So as an organization that is representing nurses in Tanzania and having WASH as your standing agenda, how do you see the prioritization of WASH at the national level at the moment? Karibu, Daktari. Thank you very much, Dr. Happiness. And I'm really happy to be part of this panel discussing about we are the professional association. How do we see the prioritization of water, sanitation, and hygiene at the national level? So first and foremost, I would like to congratulate the previous speakers for a very nice presentation. And I would like to join my hand with them by saying that we as TANA, a professional association, we believe that prioritization of water, sanitation, and hygiene at the national level is crucial in improving healthcare service delivery and public health. Because without having the proper water, sanitation, and hygiene, it's very difficult for us as professionals to provide the effective healthy services. So water, we all know that water plays a fundamental role in preventing the spread of infection from one person to another, but also ensuring patient safety and creating a conducive environment that enables all the health professionals to provide a care which will reduce the spread of the infection, but also building the confidence to these healthcare professionals. Now, what is the level of prioritization of water, sanitation, and hygiene at the national level? Now, in order to address this issue of prioritization of water, sanitation, and hygiene, we need to remind ourselves about the Sustainable Development Goal number 6 and the Sustainable Goal number 3. These are the key sustainable development goals which address the issue of water, sanitation, and hygiene. And we all know that without adequate water supplies, without adequate sanitation and hygiene, it is very difficult to achieve these two sustainable development goals. Now, the previous speaker, Dr. Happiness, has just mentioned the current status that we are having here in Tanzania. And I don't have to go back again and repeating the same statistics that she has just pointed out. But what we believe that we as a professional association has a crucial role to play in order to improve the situation of water, sanitation, and hygiene in our health care facilities. We know that nurses constitute about 70% of the healthcare professionals. And they are the ones who are staying for quite significant amount of time with the patients, trying to provide care. And this care that are being provided by nurses and other healthcare workers is really important to be accompanied with the adequate water, sanitation, and hygiene. We have seen that this is a very crucial issue of prioritizing water, sanitation, and hygiene. Why? Because it's a public health issue, it's an economic development issue, but also it's an issue of poverty reduction. So in order to ensure that we provide a comprehensive care to our patients, we needed to have adequate water, hygiene, and sanitation in our working environment. And our healthcare workers needed to understand the role of water in the healthcare facilities. Now, if you look at the statistics, there are different literatures that are pointing out about how far the country has tried to do a lot of efforts in collaboration with the different stakeholders and implementing partners in trying to address the issue of water, sanitation, and hygiene in our healthcare facilities. Now, having said that, there are some initiatives that the government, in collaboration with implementing partners and donors and other stakeholders, has done in order to improve the issue of water, sanitation, and hygiene. The first and the foremost initiative that the government, in collaboration with the different stakeholders, has established a guideline for healthcare facilities in case of water, sanitation, and hygiene. And this guideline right now, as we speak, is available in almost all facilities. And our health professionals, including nurses and doctors, they are the ones who are using this particular guideline. Now, this guideline now gives a kind of direction of what are the minimum standards a healthcare professional needed to implement in order to ensure that there is adequate water, sanitation, and hygiene in those healthcare facilities. The other initiative that the government, in collaboration with the implementing partners, donors, and other stakeholders, is also using the National Development Plan. The National Development Plan also has some targets that it tries to mention what are the kind of targets we need to achieve when it comes to the National Development Plan. And this is also being implemented in all healthcare facilities. And apart from that, our government, again, through the Ministry of Health, has participated in various global initiatives in order to provide quality healthcare services to pregnant women's, children's, and the neonates. And by doing so, we have a number of initiatives. One of that is there's a coalition of the initiative whereby there are 9 countries, including Tanzania, Bangladesh, and Uganda, whereby these countries has been monitored by UNICEF and the WHO in implementing these initiatives of applying different initiatives in improving the quality of services for mothers and children. But apart from that, the government, in collaboration with the different stakeholders, has initiated a communication strategy for infection prevention and control in order to make sure that we all know that in infection prevention and control, water is necessary. There's no way that we can do IPC without having adequate water, sanitation, and hygiene. So looking at these strategies that the government, in collaboration with the different stakeholders, has done, we have managed to reduce the number of deaths for pregnant women and even for neonates. If you look at the current statistics of the maternal death in Tanzania and even the neonatal death in Tanzania, it has significantly reduced. So, however, we are not there 100%. We still have a long way to go in order to ensure that we have addressed the goal number 3 and goal number 6 come to the year 2030. And there are a number of challenges that are there. And the government now, in collaboration with the different stakeholders, donors and partners, still have a long way to go in reaching the standards that we would like to see, that there is a universal access to water, sanitation, and hygiene to all of our health care facilities. Now, to mention some few challenges that we are facing, we still have a very low budget when it comes to issue of water, sanitation, and hygiene. So this is one of the challenges that the government, in collaboration with other stakeholders, are still facing in addressing the issue of water, sanitation, and hygiene. But also, we have the issue of climate change and the population growth. These are some of the issues also kind of pulling back the efforts of ensuring that we are attaining the goal number 3 and goal number 6 as far as the sustainable development goals is concerned. Thank you. Thank you very much, Dr. Mbao, for that very insightful discussion and points that you are bringing. And I think they are connecting very well with our next speaker, Engineer Herbert. Being in the field for over 30 years, I think you have seen it all, and you know where we are coming from and where we are going, at least where we are right now, but the wish of where we really wish to be, and looking at the SDGs. Linking from what Dr. Mbao has just said regarding the challenges, among others, that she has spoken, and knowing the role that TAWASNET is. Dr. Mbao, at TAWASNET, you are representing more than 60 local actors in WASH, in a space who play, and you are playing an oversight role to ensure there's check and balance on WASH sector investment between the government and other players. Looking at the challenges also that have just been alluded, being some of the existing, if you were to speak, maybe to the Minister of Health or the President, and highlight just 3 key points about the situation that has been addressed by Dr. Mbao and Anita there. The points that you will critically like them to take forward and that you really think they can bring at least a certain change in the WASH sector if we relate it to UHC. What could have been your advice?
I hope wote tunaisikiliza Kiswahili, hamna ambaye lugha yake ni ya kigeni. So if and a few of you are not able to follow in English, unasema major problems are discussed in our mother language. Si ndio jamani eh? Okay, niseme asante sana Happiness, na swali lako gumu inategemea waziri au rais nimekutana naye wapi. Nikutana naye kwenye lift, mazungumzo yako tofauti. Lakini nikikutana mara nyingi siwezi kukutana na rais sehemu ambazo hazihusiki. Itakuwa ni platform ya kisiasa. So ikiwa platform ya kisiasa na maneno yangu yatakuwa ya political right, lazima niyazungumze hivyo. Na unajua kwa kwetu Tanzania atakuwa rais Mswahili, anajua Kiswahili. Na kwa changamoto ambazo nimezisikia, na of course nazifahamu, I trust, naamini na wengi mnazifahamu kwamba tuna shida ya changamoto kubwa ya upatikanaji wa maji. Na hasa wale mnaokaa Dar es Salaam, mkiniambia mnapata 24/7 365 days maji yasiyo na tatizo, nitakuwa na shangaa. Labda kama wewe unakaa karibu ya lilipopita bomba. Kwa hiyo moja ya kimsingi ni kwamba kabla sijaendelea kwamba maji is a human right. Sijafahamu vizuri dokta kama afya pia ni human right eh? Okay. Sasa unaangalia vitu viwili. Water and wash is ni human right. Kwa hiyo kwa rais ambaye huwa kwa Tanzania ana mamlaka makubwa ya kisera na ya kifedha. Moja tu, nafikiri mmeyasikiliza hapa kwamba hela hazitoshi. Na hazitatosha, na ni wangu kule mwisho akazungumza kabisa, wamekaa miaka mingi sana mpaka wapata mfadhili, sio hela ya serikali, wapata mfadhili mwingine. Kwa hiyo ni muhimu kumchechemua rais kwamba tunahitaji uwekezaji mkubwa sana wa kifedha kama tunataka kufikia malengo haya ya haki za binadamu mawili makubwa. Haya mawili makubwa. Na bila hivyo hatuwezi kwenda mbele. Lakini nikipitia takwimu zangu ambazo huwa nazifahamu mimi hapa, mapato ya serikali mara nyingi huwa hayatoshi kukizi matamanio yote. Hata siku moja sijawahi kuyaona. Kwa mfano bajeti ya Wizara ya Maji, kwenye program ya taifa ya maendeleo ya maji, Water Sector Development Program, ina fezi 4 ambayo ilikoenda kwa miaka 20. Sasa hivi tuko kwenye fezi ya mwisho. Lakini we have never got all the money, to be honest. Katika miaka yote hiyo tumepata only 48% commitment. 48%. Na 48% ikija, tunasema ni commitment. Kwenye matumizi mara nyingi hazitumiwi zote. Sasa uangalie hiyo picha ya namna gani tunakuwa na changamoto. However, unaona hizo progress zinaonekana zinaendelea. Kwa mfano sasa hivi watu wanaopata maji safi na salama vijijini iko kama 72%. So around watu milioni 16, milioni 20 hivi hawana kabisa hayo maji ambayo tunayazungumzia. Which means hata kwenye hivyo vituo vya afya vya kwetu, we would call health facilities, maji hayawezi kufika. Na kama hayawezi kufika, na maana kuna changamoto ambazo daktari hapa amezungumzia na nurse kule kazungumzia. Lakini nikizungumza na waziri huwa tunakutana naga, na wao tunakutana naye platform nyingi tu. Nitamwambia yote ya ukweli kama yalivyo, ya ukweli. Moja, swala la kisera. Sera sasa hivi ya wash ziko tunasema fragmented. Kuna ya maji, alafu kuna ya public health. Lakini ukizungumzia swala la sanitation huelewi iko upande gani. Au hygiene. Watu wengi sidhani kama mnaelewa hygiene maana yake nini. Iko upande gani. Kwa
Kwa hiyo swala la kisera, usipokuwa na sera, kawaida huwezi kutunga sheria ya fedha kama hamna sera. Kwa hiyo ni uzuri kwa waziri ni msukume katika mfumo kwamba tunahitaji kuwa mazungumzo ya kutengeneza sera iliyopo. La tatu ambalo pia litakuwa la waziri, kwa sababu rais tutamwambia la kifedha, ni swala la sustainability. Ukisikia hadithi nyingi hapo kwamba maji yanafika, yanaonekana yapo, lakini uendelevu wa huduma unakuwa very poor kwa sababu mifumo yetu, our system ya management ya health facilities bado ni government led, yani serikali italeta ruzuku tujenge choo, serikali italeta ruzuku tujenge incinerator, serikali italeta tulipie gharama za maji. Hiyo haitatokea. Nafikiri hapa katika hatua hii tunahitaji kuwa na mabadiliko makubwa, tunaita radical changes kwenye huduma zinazotokea. Kwa hiyo hii ni kumwambia waziri. Sasa waziri akipata hiyo, kawaida yeye ana utaratibu wa kutengeneza marejeo na mazungumzo na taasisi yake. Nafikiri mimi maswali yangu yalikuwa hapa ya juu juu, sitaki kuongea detail. Nafikiri that is. Asante. Asante sana engineer. That was really insightful and straight to the point. And now I would like to go to Mr. Anitike in the place of the Ministry of Health. After receiving the reflections and hearing the reflections from the service provision level to the others who are working at institutional level, as you are representing the ministry, why do you think that water, sanitation, and hygiene in healthcare facility is important for achieving universal health coverage objectives? And I know Dr. Mbao has kind of highlighted some of the initiatives that are currently existing, but if you can also share more that are there in place to accelerate, because right now I think you are speaking about the acceleration, trying to see what we'll be able to catch by 2030. So if we can get a reflection about that from you, Karibu.
Hello. I think it is good afternoon. Eh? Yeah, still morning. Good morning. Yeah. First of all, I would like to commend a very good work that has been done by our partner, WaterAid, to convene this important session on washing healthcare facilities. You can imagine throughout the summit, this is the only session that talks about wash. So we commend that step that you have taken. And also I would like to commend the contribution from my fellow panelists who have shared their views on what is happening on the ground. We have heard from Madam here, Dr. and Engineer Kashirila, who are the experts in this area and have been working for quite a long time. Yeah, for us as Ministry of Health, really, and when it comes to the concept of universal health care, we say WASH has no alternative. We have no alternative for water, no alternative for sanitation and hygiene, the same as healthcare waste management. These are crucial and very important. And when we are talking about the universal healthcare coverage, there are three pillars, if you wish. We are talking about quality services, we are talking about equity and dignity. You cannot talk about quality if WASH is not considered. Also, Dr. Mbao here talked about the maternal deaths and neonatal deaths. If you read literature, very recent publications shows that among the leading cause of maternal deaths in the developing countries is something to do to PPH, hypertensive disorders, and number 3 is WASH. When you talk about maternal sepsis, it's something to do with inadequate wash and IPC issues. And you cannot guarantee IPC if you don't have water. So, as a government and being aware of the importance of wash, we have taken some initiatives. One of it is that before 2017, in the country, we had nothing called guideline for wash in healthcare facilities. So in 2017, that's when the country developed the first guideline for wash in healthcare facilities. And we all know the importance of guidelines because it sets standards on what is required. And it was not only the situation in Tanzania, but across, you can imagine in Africa. By the time we are developing the guidelines, we had to do consultation to our neighbors, Rwanda, Uganda, Kenya, Zambia, all the countries which are surrounding Tanzania. We couldn't find one. The only country that had guideline by then, it was Ethiopia. And actually that was not a guideline, it was a manual for water supply mostly. So we are among the first countries in Africa actually to have our own guideline. And we have shared widely to our fellows, and some have adopted it. And apart from the guideline, we also developed tools, because having a guideline is one thing, but we also have the tools to operationalize the guideline. We have developed the designs for water supply for our healthcare facilities. Imagine in the previous, especially in the primary healthcare facilities, a facility is constructed but without any consideration of water. The structure is there, but no water. Madam has talked here. She has been working in a facility for so many years, but the facility had no water at all. Okay? Now, after developing this guideline and tools, the government now has come up with a program to improve wash in our facilities. We started this program in 2019, and we are targeting to achieve around 2,636 healthcare facilities, and these are primary healthcare facilities, meaning dispensaries, health centers, and district hospitals. And to date, as I speak, we have reached 1,903. And by end of this financial year, we are expecting to achieve the 2,600 facilities. And we still have some 2 years to finish this program. So our focus is to see into it that all rural healthcare facilities where the problem is big have improved access of water, toilets not only for the staff, toilet for everyone, for staff and for the clients, and also for the people with disability. All our facilities now, which are being constructed, are required to provide facilities for people with disability. Okay? And some of the rural councils have already achieved the universal coverage of wash. When we talk about Sengerema, we have reached the universal, all the healthcare facilities in Sengerema. Okay? Talk of Mufindi, talk of Mbozi district, and several others. Okay? It's unfortunate that Dodoma region has entered into the program this year. So we'll take the name, and because the guy from Porage is also here, Seriman, we are going to deal with that facility to ensure that we do the plumbing so that water is available at every point of care. So these are some of the initiatives that really the government is taking. And as a matter of budget, we have, the government has allocated enough money, at least I can say, for the past 5 years. You can imagine wash in healthcare facilities has received around 240 billions Tanzanian shillings. And this is the money that has been committed and is available. Unlike Engineer Kasiria said that there are two things, having money in the budget and having money for the implementation. What I'm talking here, I'm talking about the money which is available. Okay, and we have already used it in 1,903, And for this year, we have planned to go into 729 healthcare facilities, and we expect by 2025, at least all healthcare facilities will be furnished with the improved water supply and sanitation hygiene. We have a challenge, yes. While dealing with the rural, urban also, the problem is growing up. So the focus now is to turn up again to look on what to do in urban areas, because much of the efforts that we have now from the government side actually has been skewed toward the rural areas. So we will keep on improving as we go, and by 2030, the vision that we have is to see into it all our healthcare facilities have improved wash services as per World Health Assembly's resolution number 72.7 of 2019. Thank you very much.
Thank you very much, Anitike, for the numbers as well, because you have spoken with examples. More than 1,000 healthcare facilities being covered. It is not a joke. It is a big work that we can vividly see, and we are seeing as we are visiting the facilities, and we can really compare where we are coming from and where we are. Just wanted to have a quick follow-on question to Anita. Since you have been in two situations, when the facility didn't have water, and then you reach the time when you have water, regardless that bado maji hayajaingia ndani lakini yapo. Unaonaje pale kituoni ukilinganisha kipindi ambacho hamna maji na yalivyokuja, labda kiwango cha kina mama wanaojifungua, watoto wanaorudi labda kwa kupata zile infection, unaona kuna utofauti wowote? Karibu.
Asante. Ya, utofauti upo na ni mkubwa kwa sababu kama tunavyofahamu maji yana msaada mkubwa sana katika vituo vya kutoa huduma za afya wa kukinga na kuzuia magonjwa. Tunapokuwa na maji ya uhakika inatusaidia sisi kuweza kuzingatia zile kanuni zote muhimu za kutakasa vifaa, za kuweka mazingira safi kwa ajili ya kuepusha mlipuko wa magonjwa ambao unaweza kutengenezwa ndani ya hospitali. Kwa hiyo baada ya kupata maji kwetu imeturahisishia hata katika utoaji wa huduma na kuweka mazingira safi na kupunguza zile contagious infection ambayo tunazizalisha mle ndani. Kwa hiyo kiasi cha magonjwa ambayo yanasababishwa na uchafu kimeshuka kidogo tofauti na hapo mwanzo. Ndio.
Asante sana Anita, and I think with that it is just a simple example showing how we can easily omit some of the infections resulting from the healthcare facilities, and also give comfortability to the patients and service providers as they receive safe and clean water nearby or into the service delivery points. And maybe I will follow on with a brief one also to Dr. Mbao. We have heard from also Anitike. He's speaking about the facilities that are there have been improved in the plan that we are having by the end of the year and by 2030. We have also seen in some of the areas where you will find all these facilities are provided, but you face the attitude issues to the healthcare providers. Facilities will not be cleaned. I think the training on IPC that you are speaking about is also still an issue. The attitude sometimes is an issue, and you may find you have very nice facilities which either are underutilized or not utilized or not maintained. You, TANA, being as an umbrella organization overseeing our healthcare providers, do you have any initiative that can be used to make sure at least there are engagement platforms or continuous learning to make sure that whatever that is being provided is translated into the service delivery? Karibu.
Thank you very much, Dr. Happiness, for that question. We, as a professional association for nurses, one of our core objectives is to ensure that nurses are providing health care according to their standards. And these standards actually are being set by the Tanzania Nurses and Midwife Organization, Association. But now, for us as a professional association, is to advocate for that issue of behavioral change. Now, we know that one of our big challenges is that we have a lot of members that are practicing in the healthcare facilities. And it's our main objective to make sure that our nurses have adequate knowledge, but not only having the adequate knowledge, but also have the behavioral change. Because we all know that when we are teaching our nurses or in the teaching, there are 3 domains that we need to address. The first one is the cognitive part, and the second one is the skill part. And the third one now is the behavioral aspect. Now, of all these 3 domains, the first one of the knowledge and the second one of the skill, that is the easy part. But one of the most difficult aspect to transfer to a student, always, it has been the third part, which we are talking about, the attitude and behavioral change. You might take a cow to the river, but you cannot force the cow to drink the water. Now, this is one of the challenges that we are facing, and there is a continuous advocacy that we are doing to our nurses to raise the image of the profession by providing the services that is acceptable to the client and to the community. So I think we agree that we still have a long way to go on transforming the profession, especially when it comes to the third domain of learning. And we will always keep on striving to make sure that we are taking the profession to the level that the service delivery is of standard, but also acceptable to those who are receiving that particular services. Thank you.
Thank you very much for that, and I will agree less. And I know there are initiatives right now of kind of having a behavioral change package for healthcare facilities, at least to help the healthcare providers to make use and to change their attitude when it comes to service provision. And WASH is also the aspect that is being looked upon. Engineer Herbert, maybe a follow-on from what you have highlighted regarding the budget and the amount that we've been able to get to date, and what Aniteke has just said regarding the amount of money that we're having. I know we have different aspects here. We are speaking about water, we are also speaking about sanitation, but I just wanted to get your general impression. If you look maybe in the past 5 years or 10 years, how is the trend of the budget? Is it kind of, as much as we are not there, but is it the allocation increasing like each year, or do we see the gap is increasing? How is it really? Karibu.
Yeah, just ni reiterate kwamba alichosema Nyitika iko correctly. Tuliokuwa kwenye sekta muda mrefu, sanitation ilikuwa haipati. Yani ilikuwa kama vile mtoto yatima. So there's major progress been done, and ndio maana wakina Nyitika wanaweza kusema wako comfortable. Things have been seen on the ground. Lakini huko zamani ilikuwa ni kugombana tu. So hiyo nyingine niliyozungumza budget ni kidogo, hii ni ile sekta nzima na program ambayo kama matamanio yetu yangetufikia huko tungekuwa tukua vizuri sana tunge accelerate, lakini wote mnajua hatuwezi kuachieve zile SDG 6, tuko behind. Sawa, kwa sababu tuko behind ni kwa sababu ya finance. Moja kubwa hapo ni finance tu. Lakini ukiangalia kwenye miongozo ya kupanga na kuallocate resources, tulikuwa najiuliza sisi wengine kwa sekta, criteria ipi inasema uipe Wizara ya Afya how much against ile national budget? Huwezi kuiona. Hata ya maji leo utasikia wamefuata 44 trillion, mwaka ujao utasikia 20 billion. Unajiuliza criteria ikoje?
Kwa hiyo kidogo undefined, na unaweza kuiona tu kwenye zile outcome indicator. Watu wangapi wanapata huduma ya maji, watu wangapi wako kwenye access kwenye sanitation and hygiene. Hizo ndio zinakuashiria kwamba we are making progress. Commitment ipo. There is a commitment kwamba tunapenda kufanya hivyo, lakini sisi wengine tunaangalia kwa juu. Sometime revenue ya serikali huwa sio nyingi ya kutosha kukidhi matamanio ya sekta zote. Sasa tunapigana, kwa mfano sisi TAWASA tunapigania kwamba sekta muhimu, afya, elimu, maji, ziwe ni priority sector. Kama priority sector, maana yake indicator ya planning iwe very clear kwamba tutatoa a certain percentage against our GDP annually ili tuweze kuachieve zile aspirations zetu. Na unajua maji ya afya ni ukifanya ni kama unakuwa mtakatifu, si ndio jamani eh? It's a holy duty. Sio tu mnafanya, it's a holy duty. Nafikiri ni muhimu tukawa tunaiona kwa picha hiyo. Asante sana.
Asante sana. I will get to Anitike later, following the time. We have 10 extra minutes, I know, from when we started. Chaz, is that correct? Okay. Okay. So maybe I'd like to give the floor to the audience to see if there's any reflection, comment, or question. And as you are addressing the panelists, I really appreciate if you'll mention the question is addressed to who, so that you get clear kind of answers. And we'll also love to know your name and where you're coming from. Karibuni sana.
Hello. Nashukuru sana. Naitwa Innocent Deus, natokea Tanzania Summit, ndio General Manager Tanzania Summit. Tunashukuru sana kwa discussion nzuri. Tunasema kuna changamoto moja kwenye sekta ya maji. Moja ambayo ni kubwa ni sustainability, kama ambavyo engineer Herbert Kashiria alivyosema. Changamoto inaanzia kwenye system nzima ya usimamizi, kwanza kwenye provisional and also supervision of the health facility of the water facilities. Previous tulikuwa tuna water village committees ambazo zilikuwa zina uwezo wa kusimamia facilities hata ambazo ziko kwenye health centers, lakini baadaye tukazitoa tukaleta KOWOSU. Lakini unakuta KOWOSU ina combine more than 3 to 4 villages. Unfortunately, katika vile vijiji unakuta kuna vijiji vitatu havina any water sources ambayo iko improved, any water facilities. Kwa unakuta yani wanakosa nguvu ya kupeleka, au wanakuwa hawapeleki nguvu kubwa kwa sababu wenyewe hawana chanzo cha maji. Kwa hapo ndipo ambapo tatizo limeanzia. So kwa sababu tuna watu wa wizara nadhani upande wa afya we have what we call health system strengthening, right? I think the same model can be used katika wash system strengthening ambayo inaanzia from the water facilities, so that watu waone kwamba they are accountable and they are responsible to make sure that the water facility is working 24 hours. But also there must be a person who is well trained to repair that facility. We should not wait for more than 48 hours after baada ya water facility kwa imeharibika. So let me stop here for the sake of time. Thank you.
Thank you very much. I have the question that I will address to Anitike and Ania. As far as universal health coverage is concerned, that is enabling every individual to access healthcare services without any financial difficulties. And actually, when we talk about access, we mean both like physical access as well as social, cultural access, which has to deal with issues like acceptability. So I was asking Anita, in his work, issue of wash, how does it affect the access in terms of cultural acceptability as your healthcare facility? By then was having an improved sanitation, hygiene, as well as no actual water supply in the place. With reference to your work, I know you are Mkunga, in your part of maternal and child health, particularly on issues of delivery services in your facility. How does it, how the access was affected by absence of those services? And in general, then I think I would like to elaborate a little bit in terms of access to healthcare, how WASH, according to the experience and different evaluation you have been doing throughout the country, how does it affect? And another question I direct also to Anyatike that, you know, universal health coverage is also has to deal with addressing issues of inequalities and equities. That is to ensure inclusion toward accessing the healthcare services. As far as WASH is concerned, how these issues of inequalities within the communities, the inequities have been addressed through the WASH program we are implementing, so as we can ensure that like no one is left behind. In terms, for example, we said among the initiative was like development of guidelines and whatever. So we want to know also in that area. And one question is on Kashilila. The way you are explaining is like it is very difficult, like the health sector alone, to achieve universal health coverage, because there is a need like collaboration from other sectors and the partners. So what do you think that will be the appropriate way to coordinate different sectors to engage toward facilitation of universal health coverage by 2030? Lastly, among the challenges which are really causing the financial catastrophic to patients as well as their cares in healthcare facilities is hospital-acquired infection and the antimicrobial resistance, in which among the causes, WASH is one of them. Because the people are going there with certain diseases, then as they are admitted within the healthcare facilities, they're acquiring other diseases. So what the government actually is doing, Anyatike, Minister of Health, to address this challenge, because I see it will be a barrier toward accessing universal health coverage. Thank you.
Yeah, it's still morning. Good morning, everyone. I am Rita Mtayoba. I work with AMREF. My question will go to Mwakitalima. First of all, I'd like to congratulate the panelists for the well-placed discussion. I just have I would like to understand more about the program that is ongoing to improve WASH facilities. And I'm curious to know how the program has taken into account the current crisis in climate change to ensure green smart intervention are taken into account for water security, as water, we know it's a scarce resource, and given the climate change crisis, probably it's going to be depleted very quickly. So I'd like to understand how the program has incorporated green smart interventions. The other question also to Mwakitalima, I'm aware that within the Ministry of Health, we have the Quality Improvement Directorate that is overseeing the IPC initiatives. The few interactions that I've had with the IPC team, and for some of the program or initiative that we've worked together, even in the technical working groups, I've rarely come across the WASH experts. I know the two are marrying one another. You cannot do IPC without WASH. I just want to understand how the collaboration is, because the efforts of WASH and IPC, they can really bring a significant impact in improving the healthcare provision. Thank you.
Thank you. We have seen other hands, but because of the time, if we can please address these ones, and we can have a bonus question if time allows. Karibu.
Mine, a gentleman called Innocent, aliuliza sustainability, ambayo it guarantee provision of water in a community systems, which will guarantee provision of water to healthcare facility. Sawa. Kwa hiyo hospitali ya Temeke hapa kama DAWASA hamna maji, na maana hospitali ya Temeke itakuwa haina maji. Kwa hiyo ile mifumo ambayo inatakiwa iwepe ihakikishe maji yanafikia watu wote hao. Sasa yeye alizungumzia kwenye management system ambazo ziko kwenye kisheria na kisera. Akazungumzia zile za vijiji, kama kutoka kijijini siku hizi imebadilishwa, kuna KOWOSO ambazo ni entity zinazowezwa kushtaki na kushtakiwa. Zile village water committee ilikuwa ni kamati ya kijiji ambayo iko chini ya mamlaka ya serikali ya kijiji, lakini walikuwa wanazikula hela sana wale miaka ile, na ndio maana hitaji la mabadiliko litokea hiyo. So, kwa hiyo wanazungumzia kwamba labda hii health strengthening system sijaifahamu nzuri, inaweza ikatumiwa kuimarisha hizi taasisi za huduma za maji, nafikiri nyingi vijijini, kwa sababu miji yote mikubwa, miji au makao makuu ya wilaya wana utility, na hizo utilities zinakuwa governed na EWURA. Kwa hiyo hili hatuwezi kutumia model hii. Model aliyozungumzia Innocent ni ile ya vijijini. So ni wazo zuri amelizungumza, lakini linahitaji liende kwenye meza ya majadiliano ambayo inabidi ubadilishe sheria ya sasa hivi ilipo, ambayo inasema KOWOSO ni kama ka utility kadogo ka kijiji au vijiji, watu wanaotumia huduma moja. Siku hizi wanaita CBWOSO, sio KOWOSO, CBWOSO. Kwa hiyo ni wazo zuri, na nafikiri itafaa kama wazo hili liletwe kwenye technical working group ya Water Sector Development Program, ambayo mara nyingi huwa wanapata mawazo mapya, mawazo mbadala ya kuboresha huduma. Na nafikiri wenye mamlaka RUWASA wana uwezo huo wa kuchukua hiyo kitu. Asante sana, ni sifupi.
Asante sana engineer. I think tulikuwa na swali lingine, nianze na Anita kabla ya Anitike. Anita, ulisikia swali kutoka kwa Selemani? Yeah, karibu.
Asante kwa swali nzuri. Katika utoaji wa huduma nikiwa kama mkunga, ukosefu wa maji ulinipa athari pia katika utoaji wangu wa huduma, hasa kwa watoto, kwa maana ukosefu wa maji unasababisha hata mazingira nilisema mwanzo yanakuwa sio salama katika utoaji wa huduma. Kwa hiyo watoto wengi walikuwa wanapata infection kwa sababu utunzaji wa watoto, mama mwenyewe maji ya uhakika hana. Kwa wanaporudi nyumbani walikuwa wanarudi watoto wengi na infection hasa ya macho, infection za kitovu, lakini hata katika ngozi. Lakini sambamba na hilo, kuna baadhi ya wakina mama pia wakawa wanapata infection kwa sababu kutokana na ukosefu wa maji walikuwa wanashindwa kujisafisha vizuri katika miili yao, na kama tunavyofahamu kuna wakina mama tunawashona, lakini pia mama anapojifungua anaendelea kutoka damu kwa siku kadhaa. Kwa hiyo kwa kutozingatia usafi, kwa kukosa maji ya uhakika, mama alikuwa anarudi pia kwa sababu ya infection. Lakini changamoto nyingine ambayo ilinikuta ni wajawazito walikuwa wakijifungulia nyumbani. Kwa sababu gani? Kama nilivyosema mwanzo, tulikuwa hatuna maji ya uhakika na ililazimu mama anapokuja aje na ndoo ya maji kwa sababu hatuna namna nyingine. Kwa hiyo kuna wale ambao wanakaa mbali zaidi na kituo cha kutoa huduma za afya. Kwa mama anawaza aje na begi la nguo, aje na beseni, na bado tuna aje na maji. Kwa hiyo tulipoteza pia baadhi ya watu kuja kujifungua katika kituo cha kutoa huduma za afya. Na nje na ukunga pia ni muuguzi, kwa hiyo tunafanya zile shughuli nyingine za uuguzi. Pia ili tupatia wagonjwa wengi wale magonjwa ambayo yanasababishwa na ukosefu wa huduma za maji na usafi wa mazingira kama kuharisha, ikiwemo kipindupindu, tulipata mlipuko wa ugonjwa. Kwa hiyo tukawa na changamoto pia ya kupata wagonjwa wa aina hiyo kutokana na kutokuwa na maji ya uhakika na kutokuzingatiwa kwa kanuni bora za usafi, kwa sababu miundombinu ilikuwa inachangia. Lakini pia tutana na changamoto ambayo kwetu ilikuwa ni msongo wa mawazo, kwa sababu hatuna mazingira safi na salama ya kutoa huduma. Lakini na wagonjwa pia walikuwa hawaridhiki na huduma. Akija kituoni anakuta tayari mtoa huduma ni na msongo, mazingira sio supportive. Na yeye pia hata mazungumzo yetu, hata yetu mazingira hayamfurahishi. Kwa hiyo kutoridhika na huduma kwa wagonjwa kulikuwa kukubwa sana ukilinganisha na sasa hivi ambapo tuna maji. Kwa hiyo tumepunguza kwa kiwango kikubwa zile infection kwa watoto, kwa akina mama, na hata ile uridhikaji wa huduma kwa wagonjwa na wakina mama pia kujifungua katika vituo vyetu. Kituo changu umeongezeka. Mwanzoni walikuwa kwa wiki kati ya wamama watatu walikuwa wakijifungua nyumbani, saa nyingine 2 wanajifungua kituoni, lakini sasa hivi angalau tunapata hata mama 4 kwa wiki ukilinganisha na hapo mwanzo. Asante.
Asante sana Anita. I think nitaenda moja kwa moja kwa Anitike. Ulikuwa
Yeah, thank you very much for
you can be brief as well. Tuna kama dakika 3 hivi.
Okay, yeah. Thank you. Okay, question from Yondu from Porach. I think the issue of accessibility of healthcare facilities versus the provision of adequate wash has been spoken here by almost all the speakers. Once you improve wash, it means you are improving the levels of cleanliness in the facility. And this is one of the things that triggers people to go to a particular facility and not the other one. Recently, we have been visiting regions as part of supervision just last week to see how improvement of WASH has triggered access to our healthcare facilities. Just as Anita said, we have noted that majority of women now, the pregnant women, goes to our healthcare facilities for deliveries because the infrastructures have been largely improved. Okay, the issues of antimicrobial resistance also has a direct relation to WASH. So once you improve WASH, it means you are in a way dealing with issues to do with the antimicrobial resistance. The question from Mutayoba from AMREF. Yes, the issue of climate change has been taken into consideration. And in our program, one of the things that we are doing is to exploit all sources of water. You know, due to climate change, the level of salinity in the groundwater has increased. So groundwater is no more, in most parts, effective for our healthcare facilities. So we are resorting into other sources, including the surface sources and the rainwater harvesting. Okay, majority of the areas in our country receive at least rain in a period not less than 4 months. So we are exploiting that source to be the source of water supply. The issues of IPC and WASH, yes, we have these two which are coexistence with the IPC team at the ministry level, as well as WASH, and we are working together. And when it comes even to developing the guidelines, the standard operating procedures, because we are sharing issues between them and us, so we are collaborating. Otherwise, thank you very much for your contribution. Thank you.
Asante sana. I would like to thank all the panelists for a brilliant discussion and everyone who was able to attend this session. And I think we are leaving this room with a very good message on how WASH is important in improving the service delivery at the healthcare facilities, reducing preventable deaths, but also adding into our economic gain as a country. Thank you very much for listening, and thank you to the panelists.
Thank you so much, Dr. Happiness and your panel. A big thank you to WaterAid for preparing this session, and to you, the audience, for being part of the conversation. We're doing a little bit of transition, 1 minute as we transition into the next Health Forum. So delegates, if you are staying for the Regional Acceleration Strategy, an innovative integrated strategy for achieving optimal program performance and sustainable partnership with the local government authorities session, then you are in the right place. And for those who are joining us in Mikumi, we warmly welcome you to this session. And shortly, once we are truly ready, I will welcome the moderator to take over. Whenever you're ready, moderator, you can join. So we haven't lost any time. We ran 10 minutes over in the previous session. So we're going to return your time, moderator, 10 minutes over into lunch. Karibu.
Asante sana, Dr. Charles Wanga. Good afternoon, everyone. So exciting to see all of us turning up to our exciting forum discussion on regional acceleration strategy and as an innovative integrated strategy for achieving optimal program performance, and critically as we think around universal healthcare coverage. So our session, maybe to start off, I would really like to introduce myself. My name is Dr. Frederick Haraka. I am the Director for Research and Evaluation for the USAID Afyangu North, and also for this time, the Acting Country Director for EGPAF. Our session today is divided into about three components. The first part of our session would be a brief introduction of what RAS is. We appreciate that some of you might have come across these innovative strategies that we had started implementing since the Boresha Afya, the previous project, and we modified it during the current project that we are doing. But we also appreciate that for some it might be the first time that they're coming across to this term. So we thought it would be a great opportunity if we give a bit of introduction of what RAS is. And once we are done with the introduction, then we'll go to the panel. I'm going to invite our panelists. We have some very experienced speakers today, as you can see. And then we'll open to Q&A session, where we'll also have an opportunity to give our feedback, reflection, but also ask for clarification. So to begin with, I would like to invite Dr. Crispin, our Director for Strategic Result Management, who's really overseeing the program implementation portfolio, to take us through briefly on what RAS is. And in the meantime, I would also ask the IT colleagues to put up the slides so that Dr. Crispin can quickly take us through before we go to the panel. So thank you and enjoy the session.
Thank you, the moderator. Good afternoon, everyone. As I've been introduced, my name is Dr. Crispin Kimario. I'm Director for Strategic Results Management for our Afyangu Northern project, a project which I'll introduce shortly. So I'll provide a quick overview of what RAS is, what do we do, how we've done it, and some few examples, then we'll go into the panel as the moderator said. Next. So yeah, this is what I've just said. Next. Yes, so EGPAF, Elizabeth Glaser Pediatrics Foundation, is implementing a comprehensive client-centered health program, EGPAF funded by USAID, EGPAF being a prime partner. This integrates TB, HIV treatment, and family planning services. So for the HIV integrated services, that includes TB and family planning, is implemented in 5 regions: Arusha, Dodoma, Kilimanjaro, Manyara, and Singida. And for the TB, we actually cover all the 6 supported regions, which include Arusha, Dodoma, Kilimanjaro, Manyara, Singida, and Tabora. And for the family planning specific interventions, we are covering 3 regions of Arusha, Manyara, and Dodoma. This is a contract, 5 years. We started in November 2021. So we have just started our year 3 of implementation. So regional acceleration strategy, why is it? A little bit of the background. During COP 2018, which is equivalent to, say, financial year 19, we had increased demand from the USAID and PEPFAR to focus on site-level support to realize the priorities that will help us actually maximize and efficiently improve our identification, putting people on treatment towards the 95 achievement. During the period, we realized that actually we needed to do a complete review of our project and portfolio. We had to do a SWOT analysis to identify where gaps are, where strengths are, and realizing regions are at different levels of performance. We also refocused the way we were doing our business. For a long time, EGPAF has been working with the Ministry of Health, PORALG, and other partners in the country through district approach, where we are largely providing technical assistance to implement the project. But this time around, we realize it's just more than technical assistance, but also a hands-on sales delivery support to realize the quick results that we wanted to achieve. So we slightly modify our focus, and knowing that the regions stood at different level of performance, and from the SWOT analysis, we also realized that there are different challenges in each region, and therefore we need to implement strategies which help us to achieve results based on the gaps that are observed in each of region, councils, and the facilities. Therefore, after the review of our package, as we were winding up our Boresha Afya, which was again USAID funded, we introduced this strategy. And we managed to demonstrate that actually changing the way we were doing business, we were able to achieve results, catch up with the gaps that we had in the middle of the Boresha Afya implementation, and finally finished up our project with good results. Next. So what is RAS? I'll leave for some time the definition, but what is important under RAS is the realization that no one size fits all. Much as we are supporting one comprehensive program, the issues, the challenges, the successes across regions are different. This also includes resources availability. So we need to consider the different opportunities we have in different regions and the gaps that exist, and decide where do we allocate the resources more and actually utilize the opportunities that exist to boost our implementation, and therefore RAS. In the design of the project, the follow-on of Boresha Afya, we took this attribute into consideration, and therefore this is our current regional acceleration strategy, which is, the aim goal is actually to build and transfer capacity to the local stakeholders. In our Afya Yango project, we are supposed to demonstrate as we implement, we actually transition and have the capacity for the same service to continue beyond the life of the project. And this is what it means. So at national level, we closely worked with the Ministry of Health, PORAJ, and I'm happy we are well represented, and also our regional health management teams and the council health management teams to design a structure that will suit the current needs of the project. At the regional level, we do have the RAS team, as you see. This is the regional acceleration team, and we have the regional medical officers in the driving seat to work with the team and the RHMT to oversee services that are within this project, but also take opportunity to drive other services that would need support. And at district level, the same happens. Our DMOs are on the driving seat at the council level to oversee the services we support under this project in line with the rest of the other services they have to do, working together with the council-based result management coordinators who is stationed, co-located within the councils to make sure that we are able to realize results. What other important aspect we have, as I mentioned earlier, it is important as we build the capacity, enable the providers to be able to do what they do best, but also do ourselves. You know, across the country, we do have the HRF gaps. The project does have a team of experts who also benefit, not only providing technical assistance, but also providing service directly when they support the implementation. That's an important aspect as well. We emphasize on the data use. It is important that whatever we design, intervention we focus on, are informed by the data on the gaps that exist. And if there are successes, actually we are able to know where we are, and therefore where should the support focus. And this is a critical element in this design. And another component, as much as we are aiming to transfer the capacity to the local stakeholder to implement, a case management approach is very important to address comprehensively the needs of the facilities for the services we support. And I'll talk a little bit about this in the next slide. Next. So if you would ask yourself, what is this? What makes RAS? What I'm showing here is there are critical elements that are parts and parcel of the success for this implementation approach. And this also is designed with sustainability thinking behind. The joint involvement, and let me define what joint means in this aspect. When we increased our effort during Boresha Afya, facility providers and project teams were in the forefront to make sure results are realized. But we acknowledge there are a lot more people who can contribute to achieve results and actually sustain what we achieve. So the joint emphasis is right from the national level. So Ministry of Health, PORAJ, community development, and other national level partners understand how we implement this. When we go at the regional level, the RHMT and the stakeholders around in the region, partners, CSO, are involved in the discussion on what to prioritize. And again, as I've mentioned already, the data-driven emphasis and innovations. We are working in a kind of resource-limited settings. So we need to innovate. How do you use the little resources we have to achieve the goals that we have to achieve? So we innovate. Where we would be going to facilities to do everything we will do, we can do some of the things virtually to still achieve the same goal. And I can't overemphasize the importance of the stakeholder engagement at all levels. And actually, by stakeholder engagement, we also recognize the contribution of the beneficiaries, the community organizations, and each facility leadership, including healthcare workers who are our critical partner in achieving results. So these are the things that you would consider are critical elements. And on your right side, I'm showing one of the platform. How do we bring all this together? You are seeing a team of planning for our CCHPs, which draw all the councils within the region and some important people who have to contribute to plan comprehensively for their councils and also for the respective regions. And that is a team for Arusha. Next. As I said, a little bit on the case management. And this is the component that we are saying it helps us to transfer the capacity to the local stakeholders to continue to implement. Case management approach we are talking about here is a systematic process that assesses the needs of the project, of the facilities, of the region. It depends on the level you're talking about to understand the gaps that exist. What will it cost or will it mean to increase performance in certain areas? And once this assessment process is completed, it helps to plan. That will be the next step. So we are not just planning because we have resources, because we are funded, but we are planning because the assessment shows that these gaps exist, and the best way to address them is 1, 2, 3. We need to monitor what we plan, make sure that we are able to achieve results. Thank you, and I'll go faster because of time. The next will be to implement the interventions that we have agreed together. We also need to monitor and coordinate the implementation to identify potential overlaps for synergy to make sure that you're actually becoming so efficient using the resources we have in the region. Thereafter, we evaluate what we've done and plan again to address remaining gaps. At the end, we are able to celebrate success. Next. So this is one of the comprehensive and integrated planning tools. It's just a template, but with this template, you're able to identify where do you need to go physically, what resources do you need, which facilities can be supported virtually, and at the end of the day, you are able to review and redirect your effort. And this template is updated on a weekly basis so that we are able to inform progress as we address the gaps and challenges in real-time manner before the quarter ends. Next. Another example where we are showing how the case management approach works. Here we are showing different capacity transfer between project teams and the RHMT and the CHMTs, and we are demonstrating the powerful of using the CQI dashboard to inform existing gaps, but also plan with the team accordingly to address them. And this has now been a culture. It's not just for the RHMT, CHMT, but also facility providers appreciate the ability, the power they get from this tool to be able to direct their effort. Next one. Again, on the same, data is everything. Data informs us where we should go. So we're also using the scorecard for different indicators to inform and prioritize where do we increase effort. And this is done jointly. The project team, the RHMT, CHMT, and the SO mentors who move around to support service provision, and the selected facilities where the gap exists. And again, this is also a demonstration of how powerful this thing is. You could see a list of facilities, what the gaps are, and how we use this to implement. Next. In a nutshell, I'm not sure if that's in a nutshell, but thank you for listening.
Thank you so much, Dr. Crispin. I think that was a brief, little bit more about RAS. I think we'll get into the discussion, and maybe that's where we'll get to understand it more. So before I introduce the panelists, I would like also to recognize the presence of our contract officer representative, Mr. Moses Batiganya. If you can stand up, please. And all the PEPFAR colleagues, if you can stand up, please. Thank you so much. And thank you so much. Thank you so much, Godfrey. but also our Deputy Chief of Party for the project, Roland, if you can just stand. Right, so we are ready to start for the discussion. And I would like to start by calling upon our speakers of today. And our first speaker would be Dr. Ntuli Kapologwe. Daktari Karibu. Dr. Ntuli is the Director for Health, Social, Welfare, and Nutritional Services at the President's Office, Regional Administration and Local Government. He's an experienced colleague. If you have not met Ntuli, you have not programmed in this country. Professionally, he's a medical doctor with specialized training in public health at a master's and a PhD level with over 20 years of experience. So we are very lucky today to be in this room. Karibu sana, brother. The next speaker is Tausi Idi. Dada Tausi, nakuomba upande mbele. Tausi is a person who lives with HIV. She lives in Manyara. She's from Manyara, but she's also a member of NACOFA. Tausi atatupa uzoefu wake wa kushiriki katika miradi kama mnufaika. Asante sana Dada Tausi. We have some slight changes. Unfortunately, Dr. Beth Magoma, who should have been here, is not around. Dr. Magoma is the RMO for Dodoma region, but is represented by Dr. Ahmed, Abdul Ahmed. Dr. Abdul Ahmed is the regional AIDS control coordinator with over 9 years experience in public health. He's been working with us, planning together, implementing together. So he's really conversant about what we do in the RAS activities. So thanks for coming, and we look forward to learn and hear your experiences. And lastly, I would call upon Dr. Crispin, our strategic research director. So one thing special about Crispin, you might recall that PEPFAR was celebrating 20 years of programming in Tanzania. Crispin was there when they started. So he started the first project, so he also has 20 years of programming in this country. So let's hear what he has to tell us today. So thank you so much, and this is our panel today. Now, I'm going to start off by really getting some reflection from Dr. Ntuli, as I introduced, is very, very much experienced. Daktari, my understanding, and we all know that in the context of the local government where you really, you are the champion. We know you're a big champion of primary healthcare and universal healthcare coverage and thinking around human resource for health. Where are we standing, and what do you think would take to achieve sustainable programs, particularly programs that we're doing around HIV, TB, and family planning? Karibu. Our IT colleagues.
Thank you very much.
Yes, thank you.
I must say I appreciate for being in this panel. And as far as the healthcare financing, human resource for health is concerned, and disease-specific program, we are doing pretty well. And I believe that should we continue with this pace, then we shall be able to bend the curve for HIV and some other related communicable diseases by 2030. But working at the local government level or primary health care, we believe this is where all the programs converge, and this is where the integration of services is happening. So investing at the primary health care is where we should all of us focus on if we are to succeed at the 100, not 95, but the 100, and 100. We need to focus on the primary health care. With regard to the issue of human resource for health, the government of Tanzania has invested heavily at the primary healthcare level. So as a result, now we are seeing we have a 52% gap of human resource for health. But that is not the challenge at all, because what we have witnessed are partners like EGPAF, partners like the non-state actors and the private sectors, they have been able to bridge that gap. So we have some healthcare workers who are employed on contractual basis to the tune of 5,000, and they are deployed at the primary healthcare level. And this is a massive support to the government. Initially, it was very difficult to get healthcare workers working at the public healthcare facilities. But of late, now we are seeing different partners coming and working with the government and supporting us in the area of human resource for health. And that's a huge relief to us. Because initially, I remember in 2004 or 2005, we could get prescriptive human resource that, okay, we'll be giving you the data clerks, but not any other human resource types, but with cadres. But nowadays, we are seeing now the EGPAF, other partners coming up with different cadres supporting the government. And in so doing, this is why we see even the targets are improving as days goes by. And we believe if we continue with this type of relationship and partnership, surely we shall be able to contain this disease even before the set timeline. But when it comes to the regional acceleration strategy, to us, this is one of the strategies which we support it dearly. The reason why we support, the partners brought in the innovation, and they were able to co-create with us and also implement together from the planning to the implementation. As you know, our healthcare system in Tanzania is highly decentralized. Much of activities are done at the primary care level, including the comprehensive plans and also the comprehensive cancer plans. So these two needs different stakeholders to make them comprehensive. So under regional acceleration strategy, what we have witnessed, we have partners going to our facilities, prioritizing together, using the data which are generated by facilities, and coming up with a plan and budget. And the district councils, what they are doing is to consolidate individual plans in different coming up with a comprehensive cancer plan. This is the only way we sustain this effort, even after EGPAF or even after any other partner. Because in the end, all what we want is to see the sustenance of this initiative. So this is one of the examples which we as a government support, and we see that, and we try to encourage different partners to use the similar approach in working with the government. But the other thing is the issue of local data use. Through regional acceleration strategy, we have seen now the colleagues who are working at the primary healthcare level, they are starting slowly to use. Initially, they were forwarding data from the lower facilities to the next level, to the district or to the regional level. But with this one, when you get to speak to them, you see they are owning the data in those facilities which are implementing this strategy. So we think this is a game changer, and we want to be able to achieve if our colleagues cannot use the data to themselves, but are waiting for other people to make decisions for them. So for me, what I would say, Dr. Raka, this is one of the very important initiatives. And for us, we do not want to be confined to the only regions which are supported by EGPAF. Rather, we want it to be scaled up to the entire country, because we believe with some other partners from different areas, then we will surely reach to where we want to be. But the other thing which I thought I should talk about is the site level support, and also managing the expectations around the mentorship, coaching, and supportive supervisions. This is one of the very important initiatives which create impetus for us to be able to go now for supportive supervision, targeting the areas which we are being challenged most. And in so doing, I believe also that this is something which need to be embraced by different people, by different colleagues within the government structure, and I'm happy we are having a regional AIDS control coordinator. This should be the way forward if we are to realize the universal health coverage. Because with universal health coverage means leaving no one behind, and having this innovative approach which are holistic in nature, sure we shall be able to realize that dream. Thank you.
Asante sana. Thank you so much, Dr. Ntule. I think very, very quick, he's really highlighted on integration, partnership and collaboration, RAS as a game changer, but also the use of data and how this has been useful in supporting sites and managing expectation. Asante sana, Chief. So I'm going to get back to you, but now let me go to Tausi. Dada Tausi. Apologies for those who don't understand Swahili. I'll try to translate as she speaks, but maybe some of your neighbor might help to really say a few words if there are issues that are critical for you to understand, but then I'll try to translate. Dada Tausi, mzungumzaji aliyepita ni mkurugenzi yuko pale wizarani. Amezungumzia masuala ya mwendelezo wa kazi ambazo zinafanyika hata baada ya miradi. Unajua miradi huwa inakuwepo kwa kipindi cha muda tu, alafu baadaye sisi tunaobaki tunaendeleza. Sasa wewe kama sehemu ya NACOFA na mnufaika, ningependa kusikia ushirikishwaji wako katika mipango, lakini pia mawazo yako juu ya mnayoyafanya, na unafikiri nini baada ya miradi kuisha mnaweza kuendelea, ni mambo gani mnaweza kuendelea, changamoto kama zipo. Tunaomba kusikia mawazo yako juu ya hilo. Naomba tumpatie microphone.
Kama alivyosema, kwa jina naitwa Tausi Idi, natokea NACOFA, lakini pia ni mnufaika wa miradi yote au wadau wote. Kwa hiyo kama ulivyoniuliza swali la kwamba je, ikitokea shughuli zetu kubwa, kwanza sisi kama NACOFA kwenye jamii tunafanya kazi ya kutoa elimu ya matumizi sahihi ya dawa. Tunapeana elimu hiyo kupitia vikundi ambavyo tuko navyo kwenye halmashauri husika, na sio kwenye halmashauri husika, kwenye kata ambazo wanatoka wanachama wa NACOFA. Kwa hiyo NACOFA tupo nchi nzima, lakini katika mkoa wa Manyara tuko kwenye wilaya zote, na endapo itatokea labda wadau hawatatusapoti, tumejipanga kufanya kazi sisi kama sisi kwa kupeana elimu, lakini kwa kutoa michango midogo midogo ambayo tunakuwa tukikutana kwenye vikundi tunaifanya wenyewe sisi kama wanachama wa NACOFA. Kwa hiyo tuna ada zetu kidogo kidogo ambazo tunalipa kila mwezi, tunajiwekea kwenye akaunti ya kikundi husika, lakini hivi vikundi vyetu pia vinatambuliwa na halmashauri. Na baada ya kutambuliwa na halmashauri, huwa tuna desturi ya kuanzisha miradi midogo midogo ya kujiingizia kipato sisi wenyewe, lakini inaweza kutusaidia kujipatia riziki za kila siku au mahitaji ya kila siku. Lakini pia tu sio hivyo. Kwa hiyo pale tunapokutana kwenye vikundi ndipo tunapopeana hii elimu ya matumizi sahihi ya dawa, lakini pia tunapeana elimu ya kupima wenza, kuilinda, kwa maana ya kuilinda jamii inayotuzunguka na tunapeana elimu pia ya kupima kipimo cha HVL. Kwa hiyo tunafanya kazi na serikali, lakini hivi vikundi haswa huu mmoja wetu katika halmashauri unaitwa konga. Hizi konga tunazo kila halmashauri, lakini kwa sasa tunafadhiliwa kama hivyo nilivyosema, tunafadhiliwa na NACOFA, lakini na serikali, lakini na wadau wengine wanatusapoti kuweza kufanya hizi shughuli. Lakini kama nilivyosema, tunaweza kujiwezesha wenyewe kwa kuchangishana michango midogo midogo kupitia vikundi ambavyo viko kila kata. Kwa sasa hivi ndivyo tunavyofanya shughuli zetu sisi kama NACOFA. Lakini tukija upande wa ushirikishwaji tuna furaha kwamba tunashirikishwa na wadau wote wanatushirikisha vizuri, kwa sababu tunashiriki vikao vya halmashauri. Tuna kitu kinaitwa SIMAK ndani ya halmashauri. Hicho kitengo kipo chini ya ustawi wa jamii. Kwa hiyo tunashirikishwa kila baada ya miezi mitatu kwenda kutoa maoni yetu kwamba ni huduma zipi labda tunatarajia tupewe, au tunapata changamoto gani. Kwa hiyo tuna furaha kufanya kazi na wadau au na serikali, tunafurahi inatushirikisha. Lakini kuhusu mrejesho pia huwa tunapata kupitia vikao ambavyo tunashirikishwa. Tunapewa barua au tunaitwa, tunakwenda tunashiriki kile kikao cha mipango ya budget ndani ya halmashauri. Hata vikao vya mkoa huwa tunaitwa, tunashiriki. Kwa hiyo tunajisikia furaha na amani kwamba na sisi sasa ni watu ambao tunatambulika, tunafurahia afya zetu, lakini tunaendelea kusimama kwenye mwongozo ule wa serikali wa kuhakikisha Tanzania bila ukimwi inawezekana ifikapo 2030.
Asante sana Dada Tausi, nitarudi kwako. So very brief for those who were struggling with the Swahili. Well, she has described the way that they have established a small revolving funding to support their activities, which are mainly towards education and towards education on drug adherence, and as well as following all the procedures, including HVL collection. But she has also highlighted how they have been involved in planning, and like the way Crispin said, when it comes to RAS, the program approaches the district without a plan, so the plan is co-created, and during co-creation they are also involved in that planning process. So asante sana Tausi. Now let me move to Dr. Ahmed. Dr. Ahmed, you are the RAC of Dodoma. So I would like you to tell us and highlight some of the practical issues that you were involved in implementing program using the RAS strategy, and tell us if there are any success or challenges that you have experienced so far. Thank
you very much. I'm honored to be here to present in this nice knowledge. As we have seen this innovation, as the Dodoma region, we've been participating full in the RAS approach from the last year of USAID Boresha Afya, and the 3 years of USAID Afya Yangu. So as a regional teams, as I remember during the last 2019, the Dodoma regional was among the regional with the least performance in the first 95. We had been, at that time, we were around 68% of the people who know the HIV status. So the Ministry of Health and Pillage had a national acceleration plan for HIV, or in order to reduce the gap for the first 95. So coming with this innovation of regional acceleration plans, of which, as we've seen, it's a very collaborative and data-driven approach that we're being involved together, and we're set to assess some of the issues that were hinders to achieve the first 95. So to my experience through this, we managed to have different planning and prioritize some of the key interventions that we had to achieve the targets. And through this, and through RAS, as it is, we are participating in planning, evaluating, and monitoring of the various interventions that we've planned together. For now, we are proud to say through RAS and other interventions, we've been able to reach the first 95, and we're about 95.7. So the RAS approach, the engagements and data-driven approach that we have in the monthly and weekly plan that we have in various facilities has managed us to achieve the major gaps that we have in the first 95. Because through RAS, despite Comba, we use the program's budget, but we were able to use to encourage councils, also to set priorities based on areas that will improve maybe identifications or linkage of client treatments, as well as facilities budgets. So the RAS approach to us, it has been a major innovation that we have used together, the programs and collaborative with the other IP and regional to achieve the first 95, as well as the second and the first and the third 95s. So the challenge, maybe the most challenge that we have, lack of resources, as the director say here. We have seen the current directions to improve primary health care and improving the financing in health sectors. So we believe through that we'll be able to reach and sustain some of the intervention that we have done with the RAS. Thank you.
Thank you so much, Dr. Can you clap for him? So a very quick follow-up to Dr. Ntuli. So Dr. You said you believe that RAS is an innovative strategy that should not just be limited to the regions that the Afya-Yangu North is being implemented, but rather really scaled up. So I would like to understand, so from the strategic point of view and your leadership, how would you really advise in going about scaling up this strategy, and what would be the steps, or how would you really recommend how the program should go about?
Thank you very much. And I think it was last week when we had the meeting with regional, AIDS control coordinators from 26 regions, and TB and REPROS coordinators. So among other things, we were able to discuss the best approach to scaling it up, because what we have from Dodoma regions, especially on the first 95, it is quite very massive. Regional medical officer together team to discuss on how best we can do that. So now we have evidence, and with evidence, confidently go ahead to scaling it up. That's why we are encouraging our partners that we should have a very good system of documenting whatever interventions we are implementing, because from there then you can easily actually invite and convince other stakeholders to go for a scale up. So this is one of the interventions which we see that if we use, then reaching out all these targets is going to be easy, and also sustaining these efforts is going to be easy. But I'm glad also to see what my sister Tausi said. We are encouraging the community voices. We want to hear from the beneficiaries themselves. Under the President's office with the primary health care arrangement, we make sure that the community representation is well taken care during the planning process. So we have the planning team, and the composition of that planning team, it does include the people from the community. So having NACOFA, having other partners, this is all what we want, because in the end we want a very comprehensive planning process which takes care the needs and demand of different stakeholders. So having Taus here is one of the things which we really want, and we encourage even other partners to follow that approach.
Thank you so much, Dr. So I'm going to move on to Dr. Crispin. So, Dr. Crispin, like I initially said, you've been in this game for over 20 years. Day 1 to day 2023. So, what has changed in terms of programming, and how do you see the country achieving sustainability, but also achieving epidemic control? And what sort of strategy, how does RAS really contribute in that? Thank you.
Thank you so much. Can you hear me? All right, thank you. Nice question. It's true that I've been lucky to be working with within HIV programming since the beginning of PEPFAR, and actually since the beginning of the HIV care entertainment program. We did the pilot during that time. A few colleagues here are also present, I see Aisa and others. But really it has been a privilege to witness the HIV programming and how the HIV programming has also benefited the other health services at all levels, to the primary healthcare level. Having witnessed the different phases of PEPFAR programming, and you would agree with me, HIV under PEPFAR support, and actually in many of our countries was needed emergency response. So a lot of resources to actually identify and get people to treatment. It was quite a number that we needed to reach in the emergency phase, and we gladly achieved that. Also saw PEPFAR programming moving to PEPFAR phase 2, where in addition to continue to reaching people who are living with HIV with the treatment, it was also important to formalize some of the things and the support that was bringing in country through the partnership framework. That's another phase where with the PEPFAR, a framework that guides implementation and resources that we are doing in reflection of the achievement that we were making. And that by itself also contributing to expansion of the number of people who were put on treatment, without forgetting that the prevention components and support that was part of it. Over this period, we also witnessed investment in the health system, infrastructure improvement, and growing a number of people who needed to get support being reached. Coming to almost late, but not the current one, the PEPFAR 03, further stabilized and moved to more of epidemic control strategies. And then in support of the UNAIDS 95 epidemic control achievement, so several elements were also included, which include the impact. So we need to see how what we do effectively and efficiently contribute to the achievement of the epidemic control targets. In addition to impact, we also need to see how sustainable are the interventions that we are implementing as a country, as partners and within regions, actually demonstrate a sustainable model. This can be continued and it can be done by anybody. And also how other, like country investment into the control of the epidemic, and also how can we sustain this. The partnership is again another component which is still being emphasized, and this includes both global and in-country partnership. So the government with the partners and everyone, we can reach extra mile. But and that's where now when we go to the reflection of, the other important component is integration. For those who remember, HIV programming started as largely a vertical program with a lot of fears that we can try to integrate, and everybody was scared. But we have moved to a phase where we see we are actually able to integrate HIV care services from prevention, care and support with the other disease illnesses. And this is a component that needs to be strengthened. And the integration could include how do we transparently allocate the resources to manage it, but how do we take advantage of these platforms to actually reach other people, the PLHV with other services, and vice versa. So we envision we actually need to integrate, not integrate other services within HIV platform, but also HIV in the other platforms to be able to maintain the epidemic control. If you put this all together, you realize why the design of this implementation approach, as Dr. Tulu has rightly said, this focuses, and actually it doesn't leave any level of the healthcare untouched. And if implemented with the fidelity, we are able to sustain, one, the gain, but the capacity to continue to be offering this. When we were launching this conference, one of the key, and I think the discussion will continue, is financing of the health system. But with this facility, if implemented with different fidelity, we also are able to identify potentially locally available resources that could contribute to support of the HIV care and the other services. And as we expect probably the other financing mechanism come over, so we could, it is still to be proven, be confident that we're actually able to provide these services to the population of Tanzania without fear, even if project come to an end. Thank you.
Thank you so much, Dr. Crispin, for taking us through from where we started till today. So we envision this session to be very interactive, and I'm soon gonna open up for reactions, questions, and comments from the audience. Please introduce yourself and say where you want to address your comment or direct, so my panelists can really get the questions clearly. And for questions that are addressed to Tausi, please, if you can say them in Swahili, tutashukuru sana. So before I do that, nataka nimuulize Tausi swali la mwisho ili tupate uelewa. Dada Tausi, mkurugenzi pale wa wizara amesema amefurahishwa sana na kujua kwamba unashiriki kwenye masuala ya kupanga mipango, unahusishwa, mipango inapangwa. Na wakati Dr. Crispin anatuelezea kuhusu rasi, alituambia moja ya component ya rasi au moja ya mikakati yake ni kuhakikisha kwamba wale wanaoshiriki wanapewa mrejesho. Nilitaka kufahamu uzoefu wako katika eneo hilo, katika ushirikishwaji na upatikanaji wa mrejesho na namna ambavyo mnafanya baada ya kupata ule mrejesho. Asante.
Asante. Baada ya kushirikishwa, kama nilivyoelezea mwanzo, tunashirikishwa kwa kupewa taarifa kwenye ofisi zetu za Konga. Tunaletewa barua au afisa maendeleo ya jamii anatuletea barua ya mwaliko. Kisha tunashiriki kile kikao, na baada ya kushiriki kile kikao, na wao wanaturudishia mrejesho pia kwa barua. Au kama sio kwa barua, vingi tunaona mabadiliko kule katika CTC, huduma zile ambazo tunazipata. Kwa moja sisi tunajua ni mrejesho wa ile changamoto ambayo sisi tulishare. Kwa hiyo mrejesho tunarudishiwa asilimia kubwa kwa vile vikao tunashirikishwa, lakini pia kwenye kama nilivyosema kwenye kupanga bajeti pia tunashirikishwa. Kwa hiyo niseme hatujaachwa nyuma.
Asante.
Tunashirikishwa kwa kweli vizuri tu na tunajisikia amani, sababu na sisi tunaona ni sehemu ya maisha yao au ya maisha yao pamoja. Kwa hiyo tunafurahi kushirikishwa na tunaomba tuendelee kushirikishwa na wadau wengine kama hivi. Tunaendelea kufurahi. Asanteni.
Asante sana. Thank you so much. So this is the time to also hear from you. Karibuni. Just raise your hand and our ushers will bring the microphone. If there are any comments, pale alafu kule kwa Godfrey and then kwa Dennis pale.
Thank you so much. My name is Stella, coming from Palladium. I would like to congratulate the panel, the presenters for the great presentation. I love the fact that your TA is really customized to address the needs and context of your client. Mine is a small one. I saw DLT and DISC app, and I thought it's a great one. I wanted to understand whether there's been any conversation, and this goes to EGBAF, whether there's been any conversation on the government to sort of adapt such innovation, but also just wondering whether there's any connectivity with any of the government health information systems.
So there was another hand. Yes, Godfrey, karibu.
Asante sana. Allow me to stand as a sign of respect for every one of you here. My name is Godfrey from USAID. Well done for great work. I think EGPAF has been known to use the regional model for about 10 years now, and this is great. I think mine is adding to the session we had with Dr. Ntuli this very morning on performance contracting, something around that. I think looking around how the government is looking forward to strengthen the role of the regional health management team, this council health management team and so forth, and putting more like a structure that allows to like do exactly the same that happens. So my question, or rather comment, goes to Dr. Ntuli, to see where perhaps there might be linkage between this and the other strategy that the government has already put inside. And that perhaps will answer the question on how to scale this further to other regions as well. Thanks.
Thank you. So there was a hand from Dennis, and then we'll take another question from there, that one, and then yes.
Yeah, thank you. Let me stand too as well. I don't know whether are questions or suggestions. Thank you very much for a very good presentations and contribution from the panelists. My concern or my question, whether it was presented or not, is how this strategy is scaled down into the level of facility. I know some of the regions you support have different kind of populations and kind of mobile populations. I don't know whether you've been able to scale it down from maybe it's called a regional, whether you have district facility and maybe special population kind of strategies to ensure that they as well receive quality or sustainable kind of service. Another question that goes to as well to the Crispin is you presented a tool. I think I like it too, but I don't know whether it is or there's a way to improve to ensure that I saw there's kind of a problem and activities to be done. I don't know whether you have a place whereby you can clearly highlight the indicator that is highly affected by the program, maybe the baseline, and as you implement it to see whether there's an improvement in terms of performance. So these are the two questions.
Thank you. Can you have the mic behind Dennis? So when you ask, just say who you are addressing, and then so that they can get the questions, because we're taking as many as we can. Yes.
Hello, my name is Sheriff Sise, and for USAID. So my question will go to Dr. Crispin, Dr. Ntuli, and Dr. Ahmed. So it will go from the supply chain to the human resource, and also what the regional office are doing to make sure that the trainings are being budgeted from the dispensary level. So from the supply chain standpoint, Dr. Crispin, you mentioned that your activity is data-driven, which is really good. I'm coming from the supply chain DQA last week, specifically in Arusha. So what we are seeing there in terms of data from the dispensary to the regional level, there's a lot of challenge there. And part of the challenges is because the supply chain that is happening above site and the one that is down the facility level are not communicating or coordinating very well. When you go to the regional office, they said we need more DQA. But you notice that many of our IPs, they have DQA, and they are doing it from their specific regions. And it happens once a year. So my suggestion would be, if we can coordinate that DQA to make sure we can do it not only more region, but also one or twice in the years, so we can coordinate those activities. And during that DQA, we went to many dispensaries. Some, I was thinking that my friends are trying to kidnap me. It's very far. But what you see there is, you go to the dispensary, you have 2 nurses that are working they are doing their own scope, but they have like 15 or more register, ledger, arena to complete on a paper basis. So if we are IP there, we are trying to get data from those people and taking all their time they are supposed to perform their normal duties. What are we doing as, ECPAF or all those IPs to make sure that we help those people to perform well? And from the supply chain standpoint, I think we are missing at the facility, down the facility level. If you see even the summit, somebody was telling me that supply chain people and digitalization people, you are missing in this healthcare, Tanzania Health Summit. And because most of us, when we talk about health, we kind of ignore that part of the health. And I think we should review the way we are thinking health because, as they said, no product, no program. All the program we are doing, if we forget to fix the health or the product data we have in those facilities, we are missing a lot. So for the research and the information I have, I know, for example, you guys, you cut the money that go to the supply chains. I need, for you guys, Moise is here, they need to put back that money for supply chain to make sure they perform well in their region. You have one supply chain staff that is at the higher level when you are covering 6 regions. You need to put back those supply chain people in those regions so they can at least, do their duty as they're supposed to and extend that supply chain above site activity to those lower levels so we can collect more data and have informed decisions. So to my friend, the regional officer, I think we need to sensitivize the facilities, the dispensary level, so they can be aware of the training, like impact approach that is happening at the regional level. Some of them are not aware of that because of, the overwhelm and the task they are having on their hand. Can we at least, make an obligation for each of them to have that budget that will allow them to come to do those training that will help, those data collection and data entries? Or, to address this to my friend Tuli. By the way, the book is very good. It's a very good book. And I recommend everybody to buy that book and to understand the Tanzania primary healthcare system. So can you at least help us to get more staffing in those health facilities? Because whatever we are doing here, I think the champions are those in those dispensaries. They are doing the fantastic work and they need more help. Thank you.
Thank you so much. So we'll get maybe 3 more, and then we'll give the panelists time to respond, and we'll take another round of questions. There was a question at that corner. Maybe, yes, you start there, and then we'll finish there. Start with the colleague at the end. Introduce yourself, and let us know where do you direct your question to.
Thank you. So, hongera sana ISAF and the whole team. I'm happy to see colleague sharing the insights and ideas. My name is Peter Bujari. Two, and I think one kind of spoken by Stella, but it is this one. One of the challenges we have is the data quality. I think the Arasa strategy has made it a way to increase the appetite of the data use. What would be the strategy, in your view, to increase the data quality as we see as a challenge? Number two, truly, I know this might be bigger, but let me just put it. One of the challenges that we have, apart from the numbers of the healthcare provider, is the quality of the healthcare services. And I know it's with another ministry, they give you healthcare providers. And some are not given to you because they're disqualified somewhere in the process of after accreditation. What would be your ideas to increase the quality of the healthcare providers, particularly in the privatization of the training institutions and healthcare services also becoming commodity in that sense? Thank you.
Thank you, Peter. So we'll take one there and another one, then we'll close for this round, give the panelists space to respond.
Thank you very much. My name is Adela Ndani from Panelists, Tanzania. And I have two questions as well. One, I'll direct it to both Dr. Ntuli and Dr. Kimario. The first one would be the structure. I've seen the structure, and I failed to see community health workers anywhere in the structure. And I think I have Dr. Lusubuya, we talked a bit yesterday about the vital role that they play in the community. And trying to bring them into the government structure, looking at the role that they play, not only in HIV and HIV-related diseases, but also other pandemic and epidemic diseases as well. So where does that fall into the structure? And if there is improvement into the structure, it should also include them because we see a vital role that they play into minimizing these effective diseases in the communities, as well as consultation to communities and awareness as well. So I would also like to see the presence in the structure as well. But also, I have one question to Dr. Ntuli. I think I've touched this question more than once to you. Duplication of efforts. Partners, donors, and the government as well. How do we minimize duplication of efforts? Looking at the strategy is really beautiful. I commend the work that ECPAF has done. So how do we minimize the duplication of efforts? There are several strategies that have been developed previously, and we see that partners keep developing strategies. So how do we make sure that we have a strategy and we keep improving it? And also implementation of these strategies. How do we make sure that we minimize duplication of efforts when it comes to minimizing, implementing these efforts in the communities, and also to help and expand into other regions, because if we duplicate efforts in these regions and then we're missing out on the other regions who might really need these efforts to be deployed into their regions. So those will be my two questions. Thank you.
Thank you. So we'll have the last question and then give space to the panelists to please bring the microphone to the gentleman next to Stella.
Thank you very much, ECPAF team and the panelists. My name is Dr. Sandele. I come from Benjamin Mkapa Foundation. So we have been enjoying this RAS has been implemented, and we appreciate. So as how others said, the two previous speakers, on the coordination aspect, we know EGPAF has been driving this with the local, our government authorities, the RHMT, CHMT, and the facilities, and the community as well. So I wanted to know to what extent it has been possible to leverage resources with other IPs, the USAID and the non-USAID, in the regions where you implement. How have you been able to coordinate jointly while you are interacting with these local government authorities? So that probably when one IP has some resources and when you are trying to tackle a challenge or to improve the performance, you can jointly use the resources together and achieve maximally. Asante.
Asante sana. Thank you to everyone who asked. Really great question, great comments. So we're going to go back to our panelists, and I would like to start with Dr. Ntuli, and then to Dr. Ahmed, and then we'll finish off with Crispin.
Thank you very much. I must appreciate this is a very good question. Maybe to start with Adela and Ali. Well, in our revised community healthcare worker guidelines, and also in our revised governance and leadership structure at the primary healthcare facility level, we have included the community healthcare workers as part of the planning team. So the planning process at the facility level, they'll be included there. So we'll have the community healthcare workers, but also we shall have a community healthcare worker supervisor. The supervisors are the ones who will be attending the planning and budgeting sessions. So we believe from there then we shall have the representation. But apart from them, we have some representatives from the communities who are not community healthcare workers who will be part and parcel of the planning process. But the other issue with regard to the duplication of effort, we did the mapping exercise. It was in 2020. Now we know each and every region, which partner is working there. This has helped us a lot because initially it caused a lot of friction even among the partners themselves. And you could see 2 or 3 partners who were implementing the family planning interventions coming with the same data to us, which is duplication. So at some point I had to convene a Zoom meeting speaking to them that you guys, you need to go and reconcile before submitting the data to us. Because to me that was a laughing stock because you are working as the same district council, but coming up with different data, but the same intervention. So we had to work with that one. So the other thing, all the partners here, before next month, they'll have to submit to us the letter of intent and the commitment to the President's office, but the other letter to send to the Minister of Finance. We want all the partners to actually incorporate their activities into the Comprehensive Councillors Plan. We started it in 2020, now it's working very well. It has helped the regional health management team, the council's management team, to avoid ad hoc activities. But initially it was very difficult. And the issue which was raised by Dr. Peter Bujari, yes, the quality of healthcare workers. I think that's a process. We need all of us to work together. You know, having a competent person with this needed skill set, you need to really invest into that person. And what we are doing now, we have some distant learning programs, we have some, online programs which are formulated by Minister of Health, just to help to capacitate these people. But still, you need some time for them to acquire skills and the competences they are needed to have. But I agree with you, we need the private sector, especially on the training institutions. We need different approaches to our training. One of the areas which we are challenged very much in the region is the competence of the people after graduation. And this is, I always also challenge colleagues that the competence and skills after graduation is up to you. Although the government, which can do is to create an enabling environment to make sure that its staff they are well equipped and they have got the skill set needed, but also it's an individual effort to be competent in that area. But the other thing was regarding the data quality. What I've learned, because I've been following up the issue of data for the past 10 or 15 years, what we are seeing now, there's a huge improvement in terms of data. We came from very far. Getting data in the morning different from the afternoon and different to the evening. At least now, you can see there's a coherence and consistency in terms of the data, but we came from very far. I've done a lot of research in that area. Now it's quite very promising. I can see the light at the end of the tunnel, but we came from very far. But still, there's a work to do, and we welcome all the partners to work with us. First of all, getting the quality data. Secondly, making sure that the data which are gotten from the facilities are utilized at the local level. And the other one was from CISE. CISE, I must say that now we are trying to transition from a paper-based to go to the electronic medical records. We have started with some urban facilities, and we are moving slowly to the rural facilities. The aim is to digitize and digitalize the primary health care. What we have learned with the facilities which we have started to implement as a pilot, there is a lot of consistency. You know, we are having these tour books, which you are very familiar with. Then you have the tally sheets. From the tally sheet into the monthly summary submission forms, then going to the district. You find here is 10, here is 11, but where we have put tablets or the desktop computers for collecting data, then there's a lot of improvement and consistency in terms of the data. And in terms of the book, well, we welcome, and I would like to use this platform, that these two books which we have just published are very important books. The one of Evolution of Primary Healthcare, which we have tried to document 130 years. So we started the one 1800 to date, Evolution of Primary Healthcare, but the other one on leadership and governance. So you can get the copy through the Amazon store. Then when it comes to the quantification and forecasting, the supply chain management, you need to have reliable data to enable these colleagues who are working now at the dispensary level to quantify and also to forecast. Otherwise, if you do not have these ones, then it's very difficult. But I must tell you, having those two nurses whom you find in Arusha, that's a huge step. In 2016, we had 500 facilities which were manned by a medical attendant, one medical attendant. By that time, I was the secretary to the regional medical officers team, and I was, trying to aggregate the data throughout the country and analyzing them. So we are very far from where we came from. Although, still with the gap of 52%, we need to do more. That's why I'm presenting a request to the implementing and the development partners that let us continue now with the contractual employments. We are employing people on contract basis. And also having to support the government to make sure that areas where there is critical shortage, like in Arusha, and areas like in Ngorongoro, within Arusha, within the same district, you have to travel 300 kilometers. Nainokanoka, Ololosokwa, and in some other places. We need partners to come in and support us in that area. Then the issue of how do we scale down? We as a government, that's why I was insisting the issue of research, especially implementation research. For us to be able to take up your initiative and to scale it up, we need to have the body of evidence. We need to have adequate evidences. We do not just go into scaling out, because otherwise you might frustrate the system. You know, whatever innovation which you come up, we take it as a form of reform. So up until we have agreed with colleagues from ECPAF and other people, we said, okay, this is working, and these are the findings you've gotten from Dodoma and some other regions. Let us go. So we need you, especially our partners, to come up with evidences. We work together, we generate evidence, and then we say, okay, now let us plan for scalability or for scaling it up. So I think I stop there. I think I might have, the performance contract, sorry. So we are currently working on having the performance contract. And we have taken HIV, TB, and malaria to be part of the performance contract indicators, to be included into that contract. And what we are trying to avoid in that performance contract, which we presented this morning, is to have disease-specific approach. We want to go into health system thinking. So the health system thinking is what we believe it will be able to take us where we are now to go to the next level. And we hope to start implementing it in January next year. And you shall see most of the indicators which have been presented by Mario here will be included and will be part of the performance contract. And we want to link them into what is existing right now, the DHIS tool and some other tools which we use for data generation. Thank you.
Thank you so much. Thank you so much, Dr. Ntuli, and I think you can all agree with me. That was really an opportunity to learn, and maybe to extend the learning, we should go to get the 2 books. Yes. So, Dr. Ahmed, I remember there were a few questions for you.
So if I can remember, it was about at the regional level, what are we doing to enhance the capacity of the healthcare workers in the low-level facilities, such as dispensaries. At the regional level, we do have a mechanism for providing continuous mentorships, job training, and mentorships. Through we have, at the regional level, we have a regional managerial support supervisions, which we conducted based on the available or raising challenges. So we do have a kind of mechanism that we visit facilities that have low performance in terms of the quality of services or data supplies management is concerned. So we do have that kind of mechanism, and we do job training and formal training, but leverage on these innovations for us as far as HIV is concerned. We do have set level support. So through the monthly reviews of data for logistics and service data, we do have kind of set support to those facilities that are shown that they have challenges in data quality services or provision services or logistic managements. Thank you.
Thank you. So, Crispin, we have like 5 to 7 minutes if you can address, and I know there were a number of questions to you. We will continue chatting if some are not addressed, but we also need to keep up with the time to allow other sessions to proceed. Karibu, if you can be brief to the questions.
Okay, thank you, Frederick, and thank you all for your good questions. All of them are very important, and even if we miss, we should not regard that they are not important. We'll continue to discuss about that. So I will start with the first question, which asked about the DISCAP and DLT. DISCAP, long form is actually decision-informed supervision and coaching tool. This is an application that project team are using to plan, execute, and document the supervision and coaching activities they conduct in a given period. It's an application that also can be used for both physical support and virtual support. And you are able to summarize your report, also identify issues that were identified during the coaching and mentorship, and plan again using the same tool, and this tool can communicate to the other person who needed to take actions on things that were identified. DLT is Dawat Latakwim. This is a data platform that we introduced within the project to weekly, at project level, review the progress of the different critical indicators in a timely manner, and plan again actions that will help us address the issues that are identified. So the question was, have we started conversation with the government on how can this be taken on board? For the DISCAP, we have used it within the project team, but also with the RAS team. And when I say RAS team, I'm referring to the project team, to RHMT and CHMT. At least at that level, the discussion has started, and they know how to use it. We haven't, as Atul said rightly, introducing anything needs really a strong evidence and how that leverage to existing system. So we have taken the first step. We have transferred this application into DHIS, updated to follow the format of the DHIS2. The next level is to continue the discussion what features which do exist in DHIS2 are not in the DISCAP, or in the DISCAP that can be important to be considered in the DHIS2. And that will be another step for discussion, and will not rush, as Tuntul said, we have to inform why are we making that decision. So opportunity exists, and since we're working together, we hope this will happen. Thank you, Godfrey. I hope the questions have been responded by Ntul, and won't repeat. And also, Dennis, your question was partly touched by Dr. Ntul. And one of the components you asked about whether there's still opportunity to improve the planning tool. Yes, actually we do, and we have started the process, and it's good that you also note that we are also happy to chat together and see what else we could include to make it robust. So we actually have a meeting tomorrow within the project team to continue to discuss on the next version that will replace this. And thank you for the appreciation. So since Antuli responded on the scalability of the approach, I think I will end it there. If you have some more comments, we can still discuss to save time. James, on the supply chain, I know Antuli touched greatly on this, and thank you for sharing the gaps you identified when you visited. And of course, noting the smaller HR component we do have within our project, that also is a reflection of the resources we have, but good comment to reconsider as we plan ahead, given the issues that we were able to identify, and see how we can beef that up. How is it working at the lower level facilities to avoid the repetition? I will defer to what Ntuli already said. About the structure, a colleague, this is Adela, who I think she said she had not seen the community health workers. It is the limitation of the org chart to show that, but actually when you refer to the RAS structure, the lowest level includes healthcare providers, the providers at facilities, but at the community, and we recognize, and we actually closely work with them. We have about 2,000 of them we are supporting, we are working together, and their contribution and suggestions in the project are taken with seriousness. So kindly confirm that we do have, and we are working together with them. And as Tausi also said, that is one of the examples. We do value this, and really we are collaborating together. Excuse my poor sight as I grow, So I'm trying to see what has not been touched. And in terms of how we do leverage resources with the other partners in the same field, and I will start with those funded with the USAID. But before I go into that, allow me to also recognize and appreciate the presence of colleagues we work together in this project, and I will start with the AMREF Health Africas. We are heavily represented, program director, all of you, we appreciate your presence. And with our colleague from Engender Health, so I see a significant number. Peter asked the question, but is actually representing our human center design technical providers, Matchbox Soloj, who we work with in the contract as per design. And I haven't seen any, but yes, he is also present. So my appreciation for the attendance. Now, how do we work with the other USAID-funded projects to leverage resource? We do have a good number of those. We have Kizazi Hodari, as we saw, for those who attended the Deloitte Forum yesterday. We also work with them in the North project. We do have EPIC doing the community work on HIV. We do have THPS also in some of the regions. We have AMREF in other projects, apart from what we are working together. How do we leverage what they have and what we have within this project? We do have, at minimum, a quarterly platform where we meet together and discuss our performance, including data sharing, and how does this translate to improvement we need to make on each of the project bilaterally. But we do contribute when we are planning this meeting. If we do bring a bigger number, we are funding this platform on a rotational basis. But also, what the opportunity we see working, we don't have to do the same. So if through Kizazi Hodari, for example, they already have activities towards improvement of our adolescents and children adherence, we will not do the same because they already invested on that. That's an opportunity. If that wouldn't be there, we definitely we must have support that. Another project we do have, but that is actually a sister mechanism, the AFIA and the LEV, which is supporting the HRH component for the safe delivery partner. And we do have also our regular structures where we meet, discuss, and see what are the needs for this project, what should they focus, which facilities, and when also there are changes, we are informed to also plan ahead of time on how we strategize to address those. So yeah, in a single sentence, we do collaborate, identify opportunity, and synergy and work together. Lastly, allow me to also appreciate the presence of the RMOs and the RHMTs who are here. I see colleagues from Singida, Tabora, RMO, and your team, for those who, I guess the RMO from Kilimanjaro might be here, so I met him. But thank you for turning up for this. It's an opportunity as we work together to use the feedback we got from this meeting to improve our strategy.
Thank you so much, Crispin. Thank you very much. In fact, even this session was run in a RAS strategy. As you have reiterated, there are partners, RHMT, everyone is here. So it's also part of the RAS strategy. Asante sana. So before we close, we've come to the end of the session because of time, but that does not mean the end of discussion. We encourage to continue discussing. You can reach out to us for further clarification. And if you would like to learn more, get to know how to implement RAS, get the tools and resources, we'd be happy to share. And as Dr. Ntuli has said, this is a strategy that the ministry is really keen to scale up to other regions across the country. So to wind up, I would like to invite Dr. Roland, our Deputy Chief of Party, to give a vote of thanks, and then we'll have a picture with the panelists, our USAID colleagues who are here, and anyone who would like to join is also welcome. Thank you.
Thank you, Dr. Araka, and I know I stand between you and lunch, so I'll be very quick. Now, first of all, thank you for all the discussions, our panelists, and your questions as an audience. As you can see, we have evolved in those last 20 years that ECPAF has been supporting the Ministry of Health in starting very siloed in HIV program, and right now in a comprehensive health service delivery program, tackling various diseases, including TB, family planning, other RMNCAs, and now also integrating NCD services. And as we are now moving and transitioning towards a path to country ownership, I think we have seen, and you demonstrated that we have gone a long way. ECPAF has been supporting service delivery through the CCHPs, actually giving funds to the councils through the national systems, Plan, REP, and EPICOR. And I heard also today, we are not there yet. The transition has to go further. The decentralization, the government is working on direct health facility financing are really important steps that we still have to take. And I think, but as we do that, we are doing that with PLRALs, with the RSMTs and CHMT, as they are the owners of the service delivery. It's not an ECPAF project, it's not a USAID project. The services are for the government of Tanzania through your leadership. Thank you also for all the questions. I think you touched on a couple of important areas, supply chain, HRH, but also community engagement are still areas that we need to further work on. So again, let me thank the panelists, Dr. Ntuli, Dr. Ahmed, Mama Tausi, Idi, and our own Dr. Kimario for your wise words, and the audience for coming, and of course USAID for facilitating this forum as well. So asante sana, and you're most welcome to come to our regions to witness it and exchange knowledge and share ideas. Asante sana, and karibu lunch. And of course you.
So Moses and the USAID colleague, if you can jump in front, we would like to get a picture of the panel.
Another round of applause to our moderator and the panel as they go to do a group photo. Those who've been invited, karibuni kwa picha ya ukumbusho. We meet again here at 2:30 for the UNFPA Follow the Data from Evidence to Action. That's the next session for us in Mikumi. Karibuni kwa picha pamoja, group photo, moderator and your panel, and those who've been invited, and anyone who is willing or wishing to be part of the photo, karibuni sana. You can stand at the back of the stage. You can stand. Those who are able to sit, karibuni mkae.